Hello, welcome all. This is Dr. Rajesh Taneja. I welcome all of you to this webinar, and I welcome the panelists and the faculty and the co-chairperson, Professor Pawan Raj Chalise. And I see that a lot of people have gathered. The participants that have registered are almost 200, but I can see 74 as of now. So I would request Professor Pawan Raj Chalise from Kathmandu to address the webinar and give his introductory note. Professor Chalise.
Thank you, Dr. Rajesh Taneja. I'm sure this today's webinar is going to be a very effective and informative to all the participants. So, dear colleagues, very good evening. I hope I'm audible now. Yeah.
Yes, you are.
With the permission from my co-moderator, Dr. Rajesh Taneja, and his whole team of Global Interstitial Cystitis and Bladder Pain Society, and on behalf of the organizer, I would like to welcome you on the live webinar on Interstitial Cystitis Bladder Pain Syndrome webinar, jointly organized by Nepal Association of Urological Surgeons and GI Gibbs together. Appreciation goes to Swati Spentos also for their generous support for the technical platform. And I'm very thankful to Deepthi, who is working so hard to get this happen today. I also welcome all the viewers from SAARC region. I'm sure that many viewers from the India and adjoining regions, they are viewing our programs. And I also welcome all the participants from abroad, whose constant enthusiasm always forces us to plan and execute many more similar academic events in the days to come. We request all of you to participate with your queries and send your comments, and we'll try our best to incorporate that during the question and answer sessions before the case-based discussion and after completing all the presentation. I'm very much grateful to our moderators for today's session, and I also welcome all our esteemed faculties who are presenting and participating as panelists in today's webinar. I believe that today's webinar on interstitial cystitis, which I'm going to tell it as IC later on my talks, will going to be much more informative and interactive. This particular disease is also considered as orphan disease. Most of the times we take it as orphan disease because as only handful of urologists are concerned about this condition. Many still think that is the domain of psychiatrists, and I've seen our own fellow colleagues is being referred these patients to the psychiatrist, and they consider that they couldn't find any findings or they could not correlate this disease symptomatology. But still, in this context, I must admit that there is, and it's because of the paucity of the knowledge and the research in this field. I'm really thankful to the GIBS team to consider the suffering of this concept, the suffering of this cohort and educating our fellow colleagues and formulating treatment guidelines in this region. So I feel privileged to introduce my own society, GIBS, and our today's faculties to you. Nepal Association of Urological Surgeons is a professional organization of urologists and urology-related specialty of Nepal and was established in 2005. Its main motto is to promote urology education, service, and related research activities. In this context, I would like to welcome Professor Chandrasekhar Agrawal, President of NAUS, and Dr. Mahesh Adhikari, who is the Chairman of our Board of Education. And because of this team, we are constantly doing lots of academic activities, and we look forward to have this association in the days to come as well. I'm very much thankful to Global Interstitial Cystitis Bladder Pain Society, GIBS team, especially Dr. Rajesh Taneja and Dr. Sanjay Pandey, who let us this platform for the benefit of our NAUS members urogynecology colleagues, and all interested people across the globe. In this difficult COVID time, we should not shake our hands. We should do namaste rather. But still, this joined hand between NOWS and GIBS, I'm sure we'll need to continue in the days to come. I'm also delighted to share few of our past association that Dr. Rajesh Taneja is well known among us, and he led the European Society for Study of Interstitial Cystitis group session, the joint session during our 5th annual conference at Pokhara last year. And we had in-depth discussion on this neglected topic in urology. We also had an opportunity to welcome Dr. Pandey at Kathmandu once. GIBS itself is a dedicated group against this disease, and I'm sure Dr. Sanjay is going to highlight more on this in his upcoming presentation. Today's session is being moderated by myself and Dr. Rajesh Taneja, who is the chairman of GIBS and senior consultant urologist at Apollo Hospital, New Delhi, India. We always appreciate his dedication and involvement in educating urologists about this rare and underserved disease. Dr. Sanjay Pandey is leading GIBS in the capacity of secretary, and he is from Mumbai, and he is the head of the andrology and reconstructive urology at Kokilaben Dhirubhai Ambani Hospital. Today, he is enlightening us about GIBS journey so far, and he's also putting its insight into clinical approach to IC and BPS. Dr. Manish Pradhan is a young and energetic urologist from Kathmandu, and he works in the capacity of assistant professor at TU Teaching Hospital, and he is presenting on pathophysiology of the disease. Dr. Ghanshyam Sigdal from Kathmandu is one of the members of Board of Education of NOWS, and he works as consultant urologist at Norvik International Hospital. He is presenting cystoscopy for interstitial cystitis. Welcome, Dr. Signal, as a presenter in this today's webinar. Dr. Amita Jain, our good friend from Gurugram, India, is a well-known figure in the field of urogynecology, and she was with us at Pokhara during our 5th national conference, and she had put lots of insight into the urogynecology subject. And she works at Medanta Medicity Hospital. She will be enlightening us today on the treatment aspect of interstitial cystitis. Today, we are also having case-based scenarios and discussion over the cases. Dr. Sujit Paudel, assistant professor at TU Teaching Hospital, is moderating the session. And our esteemed panelist, Dr. Siva Priyadarshi, who is professor of urology from SMS Medical College, Jaipur, India, and Dr. Apul Goyal, professor of urology at KGM University, Lucknow, India, along with other faculties, are participating in case-based discussion. After this brief introduction of faculties, now I will take a few minutes to introduce the disease and overview the problem. Interstitial cystitis and bladder pain syndrome is one of the neglected disease, also known as orphan disease, as very, very few are ready to adopt the condition. It's being neglected for so long in the history. In the community, actually it is unserved. Actually it is unserved or significantly underserved. It is not life-threatening condition and has myriad of presentations. So there are people who still believe that it is not a disease, but a chronic debilitating condition, which actually has no permanent cure. In the past, people used to believe that there are no clues to the etiology of the disease. Pathophysiology is less understood, and specific and effective treatment does not exist. As of today, we can't agree with those statements, but still, a lot of things need to be fixed, and we need to open a giant arena of research over this untouched domain. The main problem of this disease entity is underdiagnosis. Mainly it's underdiagnosis because this happens in a society that people seek lots of medical help, but still these people are underdiagnosed, and sometimes this condition is overdiagnosed and they might have having inappropriate treatment. This is due to less attention and care by the physician or by patient himself. and lack of awareness among the doctors and the disease. Even this condition is least discussed in conferences and meetings. We see that when you go to the conference, there are lots of debates will happen on the robots, prostate, lots of stones, but this kind of disease, which is neglected disease, is never discussed and they will not find a place in a conference and a meeting. Symptoms of the disease is very vague and not life-threatening, which makes it to get overlooked. At times, overdiagnosis and inappropriate treatment due to loose diagnostic criteria, underutilization of diagnostic modalities, and including similar illnesses into accounts complicate the management strategy. Patients of interstitial cystitis usually reach to you with bunch of case files. Usually they might have visited dozens of colleagues before you and might have multiple quick scopies, because many busy urologists, they perform this cystoscopy under local anesthesia, and sometimes you may not get the adequate information what you need. But their actual symptoms of agony, pain on full bladder and frequency never get relieved. This actually is a disease of exclusion. Diagnosis can only be made with high index of suspicion, and exclusion of similar symptomatic condition by utilizing necessary diagnostic modalities is must. Clinical acumen with proper treatment planning is utmost necessary for successful outcome. History is not a mystery, because we need to learn a lot from the history. In 19th century, this is defined as an inflammatory disease, which produce some symptoms as bladder, same symptoms as a bladder stones. In 1918, Hunter described an elusive ulcer in the symptomatic patients, because at that time he used a very primitive scope, so he could not describe it properly. And later it is named as the Hunter's ulcer, which is now considered as the hallmark of the disease diagnosis. The disease got a place in urology textbook only after 1978, and the term glomerulation was coined. NIDDK, National Institute of Diabetes, Digestive and Kidney Disease guideline was formed only in 1978 and was very rigid. It was so rigid that only 40% of the patients of IC were get diagnosed and got treatment. ICS used the term painful bladder syndrome only in 2002, and later the name was changed to bladder pain syndrome in 2006 by European Society for the study of interstitial cystitis group. Japan used the term hypersensitive bladder in their guidelines, while AUA gave their guidelines on 2011. All experts of the disease sat in Kyoto on 2013 for consensus meeting, but the outcome is not changed, because there are lots of societies and they still think that there are lots of discrepancy in the definitions, and the consensus guideline could not be made during that time. Talking on prevalence, the interstitial cystitis is a rare disease, not oftenly seen. The prevalence is different at various geographical regions. As more and more awareness and education is being organized across the globe, the prevalence is gradually on the rise. It totally depends on diagnostic criteria being used. Recently we said that NIDDK has the diagnostic ability of 40%, whereas ICBD has 90% ability. Utilization of highly criteria may land up with overdiagnosis and unnecessary treatment. This point also need to be considered during clinical practice. This table shows the prevalence of interstitial cystitis in various countries. Lowest is seen in China, which is about 100 per 100,000 population. Finland has about 300, while the prevalence is recorded highest in US. It is as high as 2,600 per 100,000 population. In our regions, no epidemiological studies were conducted so far, so we could not, so the exact estimation of it is not possible. So even if you assume that the lowest rate in our region or the lowest rate in our world, it's taking 100 per 1 lakh populations, it will come out to be 1.7 million people from the SAARC regions. So this is a huge amount of numbers which is currently suffering from this disease, and they are not diagnosed on time. This figure is very vital in understanding the disease and the ability to diagnose the conditions utilizing the criteria. I'm sure Dr. Manish is going to explain more in detail during his presentation, so I'm not going to take it up. different societies and associations are trying to solve the disease puzzle with strict definitions and diagnostic criteria. European Society has included chronic weak pain, pressure or discomfort related to bladder filling, and at least one urinary symptom in diagnostic criteria. While AUA, which published its guideline in 2011, they defined as an unpleasant sensation perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration. So he mentioned about the duration, the symptom has to be there for this much of durations in the absence of infection or other identifiable cause. So all the society agrees that this is a diagnosis of exclusion. So before labeling the patient as an interstitial cystitis, you have to rule out so many other conditions. Japan coined the term hypersensitive bladder, and more weightage is given to the urinary frequency rather than the pain, because all the societies are giving lots of emphasis given to the pain, vague pain over the pelvis, over the bladder region. But Japan has termed it as hypersensitive bladder, and he considered frequency as one of the major presentation. India in 2009 also formed a guideline and defined the disease. We should be very thankful to the Indian Interstitial Cystitis BPS Society, and now I'm sure the GIBS will take the lead for the upgradation of this guideline in our region. With this, I would like to thank Dr. Rajesh and all the panelists, and now to give me this opportunity to present among you. And now I request Dr. Sanjay Pandey to take this forum, and I request him to take the next presentation on GIBS journey so far. Thank you. Dr. Pandey, you're there?
Yes.
Now,
good afternoon.
Yeah.
Dr. Pavan, Dr. Rajesh Taneja, all the panelists in today's landmark event, and colleagues who have joined in from Nepal, urologists and gynecologists, and my colleagues from the Urology Society of India, and colleague gynecologists who have been partners in this disease and in pelvis in our very own journey of the last 5 years in India, and panelists whom I see from pan country, including very senior urology colleagues from the country. Thank you so much for coming in such large numbers for this presentation. GIBS, the journey which we talked today is all about the evolution that we did to have reached this level where we were able to partner internationally. The evidence that we had, which we did mount upon, the experiences that we all did take it forward to highest possible level with the expertise that we had to match the expectation of individuals who were suffering in agony and as patients. I speak on behalf of the core group, which actually worked hard to get this subject forward. So, Dr. Pavan, you in your opening sentences did talk about this very important subject, a subject of high prevalence and neglect, and a subject of agony and disgust. So we take this subject forward looking at what describes IC bladder pain syndrome globally, Nepal, India, and the entire world. And it's all about very high prevalence, which is hidden, and very high impact on the quality of life, which is so significant on each aspect, into their families, into their physical, sexual, into their entire lifestyle, into everything that they go through as years go by. In other words, it's underreported, underdiagnosed, understudied, and undertreated. And that was possibly an eye to which we were looking forward to when we thought about this entire movement. I must at this point in time also acknowledge the very importance of how any journey started with a dream. And there was this important quote from Vikram Sarabhai, which probably Vishal Jajodia, the patron right now, actually heard at some point in time. And thought about taking the subject to highest possible levels, and this was quite some time earlier than we had actually come. So that very important journey of 1,000 miles began with his single step with an attempt at the SIU meeting in 2010, where Swati Spintos was appreciated and awarded with bringing this subject to the domain of colleagues in urology and taking it forward to very high levels, those seeds which were sown that point in time. With the kind of disease burden that is actually prevalent in this part of the country, we knew that we had to wake up. So awareness to clinicians, awareness to physicians, awareness to all those who deal with urine was almost a wake-up call. And while we were looking at and doing work at our own clinics and attempting to do best, there was this very important Interstitial Cystitis Awareness Month coming up somewhere there. So there was awareness already around, and that awareness was what we were looking forward to. So the intention of GIBS, which actually came into being, was about thinking out of the box rather than doing individually. It was to combine the stakeholders, which were urologists and the gynecologists, and then reach our colleagues in our fraternity, and then possibly go ahead and reach the society, reach the patients who are in agony and living with that kind of a discontent in their life. So the intention was to give a direction, and to give a direction to clinicians, society, and the authorities too, under the very purview of guidelines and Hippocratic Oath and how we think. We decided to change the goalpost and be a team. And that change was to bring about improvement in the quality of life. And in 2015, to identify most of these patients who were suffering and who were probably being missed out, to evaluate better than what we have all done individually, to treat all aspects and not just what I and my colleagues would treat individually, but all aspects of discomfort, pain, save the bladder as a goal, and therefore to make impossible to possible and finally treat and cure them, because every life matters. What was an intention when we looked at this? So in 2015, when Dr. Kaufman was here and Swati Spentos hosted him, and we looked at the multi-city meets and looked at the entire understanding of what was happening around, we decided to set up this important organization called GIBS. So GIBS was no accident. It was stalwarts in various parts of the country who were dealing with the subject, decided to come over a round table and attempted to debate and discuss and present all that we had gone through in our journey of treating our own patients. So we were assimilating A to Z over months of meetings and talks around and looking at amalgamating thoughts, plans and expertise and evidence that we had. And we were embarking upon something which could then spread across the entire country and possibly the globe. So the intentions were beyond the horizon. It was an awareness for one and all, starting from me to everybody in the society and all clinicians, elevating the suffering of these patients who suffer from this very subject of health which has been left alone. Allays of this an important entity that if somebody has a disease, it's almost not treatable, which is not true. Taking the subject to completely newer levels, which has not been touched in the past, which was to make it less overlapping and less confusable for a clinician who almost deals with it. And I reckon every gynecologist and urologist has a part of it. And therefore, we were keen to look at involving the entire globe. And soon we had arrived on this subject, which was all fire everywhere, which means we had the inaugural GIBS in 2016 in Mumbai, which was the first scientific congress and deliberation, where we put 2 days of non-stop activity and academic work into understanding how clinicians practiced around. It was great to have people from the globe in the very first inaugural congress. The news attention that it got across in India and the kind of colleagues who came in on board to become ambassadors of this very important subject helped us to move in 2017 to a very landmark GIBS, which still stands very tall in understanding of the core group, because we had dreamt about this in 2015-16 when we came up. 2016 GIBS was important because that's the time when these months of deliberation across in Delhi and Mumbai that we sat across roundtable meetings, we could bring forward the so-called best clinical practices and safe practices for our individual patients. And that came into being as clinical guidelines for the IC bladder pain syndrome, which I would say was not everything new, but was a conglomeration of the facts, the expertise, the evidence, and how we would go ahead very safely on patients who have been on agony. Nobody was presenting on day one. So GIBS 2017 was in news in mind of all of us, because right emanating from the GIBS, it went across and we had such amazing performances. For example, the kind of interactive churning that we had over the 2 days of the most senior gynecologists and senior urologists who actually participated from the whole country has been landmark. We also, though we are sitting on a webinar today, believe me, in 2017, in a pre-lunch session, we had the most jam-packed live webinar with Dr. Windale speaking directly from Europe and enchanting us onto this very important gag layer and the understanding of the whole subject. So webinar was known to us 3 years ago before we actually landed up in a crusade of these webinars by an amazing kind of a performance that was happening. So 2017 to us all at GIBS is very close to our heart. We also did come up with this important GIBS Society website. And that's the website open for you. It's live. It has been there since that time. This is the website which has got everything that we have done in the last 5 years is all entrenched there. So the success that we have right now is no accident. It's a hard work, perseverance, learning, study, and sacrifice of the core group and all those colleagues who agreed to join on board on a subject which was possibly missing when we were doing it alone. So we knew that we is stronger than I. We decided to take it forward to the highest possible level. And then came 2018, a landmark where colleagues came in from Europe, from South Africa, from Gulf countries. And it cannot be forgotten that we brought in gut also as a very important subject. And we had a nutritionist from London who came in around. So of those 120 delegates who came in for pain therapy, from gynecology and from urology forum, we knew that we had actually arrived because we had hospital partners and we had a movement which had actually taken its momentum already. In 2019, the last year, from reaching the horizon to beyond the horizon, the theme was to look at seniors and experts who had actually done their work and life on it. And we had the senior most urologists, we had the gynecological entire fraternity participating from the very important stage that we had. We had colleagues from Europe, we had colleagues from Africa, we had colleagues from all over, and then we had live Skype sessions around. So I think we had actually arrived. Over the last 4 or 5 years, if you look at the journey that we have gone through, right from the days in 2010 when SIU did initially appreciate that it was an important disease and India had to look into, and possibly India could be a starting point from where the disease could again be given the new definition and the new ways to move forward. We did not only do the annual meetings around, but we looked at the 24/7, 365 days activities where our gynecology colleagues and our core group members became ambassadors in their own zones, in their own cities, and look forward to taking the subject to very high levels. I remember this entire meeting, which was jam-packed at the Apollo Hospitals in New Delhi, where we looked at the gynecologists sitting in the panel and asking questions to us. It was so nice to look at that we had actually busted the myths by that point in time and become partners on this subject in a very, very high level around. I can't forget that female urology update which happened in Baroda, where we had more than 200 delegates, and it was all discussion about very practical tips and tricks. That is what we are probably imparting today to our colleagues who may be new to the subject or who are here to probably polish and be partners to us. So the CMEs that we have had by our gynecology colleagues, which actually has taken to such high levels, was also to look at those important confusions that we had in gynecology. And remember, right from the RCOG guidelines and beyond, since the teachings on the gynecological circles, we always looked at various other overlapping diseases and confusable diseases in the pelvis, which was actually broken apart. Gynecology colleagues, including the core group members, Dr. Ranjana, Dr. Tripathi, Dr. Amita, they all took it upon themselves to take it to the North India and Western India, where they could take this subject about opening up and telling gynecologists that the subject is A, B, and C. They're all three different around. And finally, when we looked at the latest of the workshops which we had, was about looking at all other aspects which we may have missed out, which means that pain, which is the crux of the entire disease and therefore called bladder pain syndrome, had not been left alone. So physiotherapy, physiatry, pain therapy, which happens to be a landmark of the entire core team in all the teams that we have in this country around, was actually to look forward to give them the right credibility. And we had Dr. Bhavti Soni come in all the way from the United States of America to give us this important aspect of physiotherapy, quite a demonstrable kind of activity for the patients in Mumbai and Delhi. These were all very important aspects that in a journey that stands so tall in the history of GIBS and a history of movement which has evolved to such high levels. The physiotherapy sections which we looked at have actually stood tall because I now gather that the international conference that we held up in 2016, which was brought by Dr. Rajesh Taneja to India, we got in the entire European activity or the world activity of ESIC to India on the platform, which was actually taken over and supported by Swati Spintos, and GIBS was a successful partner at that point in time. So when we look at that, India happens to be the new benchmark in terms of more and more teams forming in terms of urologists, gynecologists, pain therapists, physiotherapists, and not only that, there are patient support groups which have come up in India. And I heard a question from Brazil that, do we have something around? So yes, we have Interstitial Cystitis India as a group, which is interstitialcystitisindia.org, where there are 556 followers, where patient support groups move together. They look at the changes happening. They are supportive of doctors as much as doctors support the group around. This is a huge awareness forum for all individuals who suffer in this part of the world. And I agree that we could probably be partners and teams around. And I remember Balaka Basu did speak on all these aspects to very high level of awareness, which has emanated from India at the very important ESIC last year. So when we look at reaching colleagues in gynecology, in urology, in pain therapy, we also attempted to reach the society. And that's where we looked at reaching the society by print and by webinar medias. Finally, we landed up in the year 2020, the year to remember, because the Urology Society of India invited us for a joint session at the first day of this important landmark conference which happened in Kochi, where we had colleagues and the core group members debate and thrash the subject to a very jam-packed audience, which actually took the subject to very high levels. More than 50 urologists and more than 60 gynecologists in the last 4.5–5 months have actually registered and taken forward the very important crusade that we started at that point in time. So GIBS has moved gradually, slowly, evolved to a level with evidence, with experience to meet the expectations, and obviously all good things take time. When IC bladder pain syndrome needs your effort and attention with those important steps that we have taken forward, we have miles to go. And today on this very landmark meeting, Dr. Pawan and Dr. Rajesh, that you did probably collaborate together and take this subject forward. We have miles to go on this subject before we achieve and really cross that important step called horizon. So challenge on many subjects get bigger, and challenge on this subject is huge. And we have gynecology colleagues who have become absolutely true partners in each country and each subject. And out here we look at ICBPS can only be a teamwork, where GIBS would drive it to every part of it. And we look forward to taking the subject to very high level. To come to a close on this important journey that we've taken forward, we are all living in an era of stress at this point in time, but we're innovating. We're in an era of competitions and evidence-based medicine, but we have decided that we'll improve the quality of all the individuals who live with quality of life diseases. And therefore, setting such standards of very high order that we've taken as a part of a movement, as a GIBS movement that we request all of you to join. I think we will take this subject to very, very high levels. Really move forward. Finally, in words of Dr. Shivam Priyadarshi, ये कहाँ आ गए हम यूं ही साथ चलते चलते, because he is one of those philosopher guides and true patriot who actually enlightens this very difficult subject in all our group meetings, and I salute him for having made the subject much lighter for patients too. So truly a challenge, friends. A dream has been realized in the last 5 years. We have miles to go, and with this important international understanding that we've opened up today beyond the horizon to reach the landmark level where we could partner with you all, I think to me, this is a great way of moving forward. Thank you so much for inviting us.
Thank you, Dr. Pandey, for highlighting Global Interstitial Cystitis Bladder Pain Society, its objective of establishment, its current activities, what you did in your country, and the reason, and how you are collaborating with different associations to increase the awareness about these hidden disease in the community. I'm sure there are lots of plan of actions with you in the coming days as well. And I'm sure many of our NOWS colleagues will join you after this meeting. I think many people will now realize that this part of the suffering in the community need to be addressed, and we need to serve the underserved community. And I'm sure we'll come together. We'll join our hands together with you. I think there will be lots of questions, and Dr. Rajesh, as my moderator, he will be answering many questions on the chat and in the question answer session. We'll take few of the questions at the end of the presentations before case-based discussion. So we'll have around 15 minutes time for question answer session. So please, I'll request everyone to come up with the questions for the speaker and for the panelist. So this time we'll move ahead. I'll request Dr. Manish Pradhan to highlight the pathophysiology of interstitial cystitis, because understanding this subject is very important. Dr. Manish.
Thank you, sir. Is the slide visual?
Yes, perfectly.
At the outset, I would like to thank NOWS and GIBS organizer for giving me this opportunity today here to present among the eminent speakers from in and outside the country. The topic that I've been given to discuss is on pathophysiology of the ICBPS. As Dr. Pawan has already highlighted the confusion in many definitions that have been put forward, the changing nomenclature about this condition and the classification system that have been used. But in a nutshell, this condition comes under the urologic chronic pelvic pain syndrome. And as highlighted earlier, the number of people diagnosed with this condition will depend on the diagnostic criteria that you use. Amongst this, now the push has been made to get the classic interstitial cystitis disease with harness lesion as a separate entity, because this has a separate pathophysiology and treatment options and different prognosis. Before we get to the core of the pathophysiology, we need to understand that this bladder-centric pain is associated with other illnesses like regional pain syndrome of eye-tone pelvic floor dysfunction, vulvodynia, or a widespread pain syndrome of fibromyalgia or chronic fatigue syndrome, as well as autoimmune mediated disease like SLE and rheumatoid arthritis. So this gives a picture as to how diverse the pathophysiology of this disease is. This is the slide that pretty much sums up my presentation. I've taken this from 12th edition of Campbell. The basic insult starts to the insult to the bladder urothelium, the interstitium, and the nerve of the bladder. This can be because of the autoimmune mediated disorders or primary neurogenic inflammation itself, the infection to the bladder, trauma, or some people may be genetically predisposed. What it does, it activates the mast cell and histamine release, changes the urothelial permeability, and the activation of pain fiber, the C fibers, and immunogenic and allergic response will lead to progressive injury and manifestation of the different phenotypes of this condition. There are basically two phenotypes. The ICBPS with Herner lesion is a robust inflammatory disorder. It's characterized by denutation of the epithelium, pancystitis, B-cell infiltration, and overexpression of genes involved in immune response and infection. And those without the Herner lesion is a distinct non-inflammatory disorder. It is characterized by preservation of the urothelial layer, and the symptoms in this patient spread beyond the bladder. So basically the pathophysiology can be discussed in these four different headings. The first of which is urothelial defect. This is generally has been considered a primary cause. Defect can be functional or a quantitative loss, which results in inflammatory response or the activation of the afferent nerves. The mechanism involved in this urothelial defect can be because of abnormality of the glycoamine-glycan layers of the urothelium or the aberrant epithelial proliferation because of the increased apoptotic activity. These two are the mechanism for those with the Herner's lesion, and for without the Herner lesion, the impaired cell adhesion could be the driving force. The other mechanism of the defect could be the toxic substance present in the urine or the autoimmunity against the urothelium. The other pathway is the inflammation. The first one is the activation of mast cell, which has generally been considered a characteristic feature of ICBPS over the years. However, the recent studies have shown that, in fact, the infiltration by mast cell is comparable to the normal bladder specimen. Hence, functional assessment of mast cell rather than the quantitative only should be performed to level this as the driving inflammatory mechanism. The other inflammation is through immunologic process. Autoimmune responses, the immunoglobulin and complement deposition has been studied from early 70s and 80s, but recent studies have shown there is also increased expression of the chemokine receptors and its ligand. So this inflammation and action is against the self-antigen or the exogenous microorganisms as well as the chemical substance in the urine. The concept of neurogenic inflammation is quite interesting because this is generally believed to be by the mast cell and its product, which induces the release of substance P and CGRP from the nerve cell, which further aggravates this degranulation. And this state of chronic stimulation of the afferent nerve cells leads to the altered neural plasticity, central sensitization of the dorsal root ganglia. And this is believed to be the causative mechanism for the persistence of syndromes in these cases. The other way around is the altered neural pathway. Recent study has shown that there is increased expression of gene involved in the pain, the pro-nociceptive inflammatory reaction in cases, especially those with Herner's ulcer. It can also be because of cross-sensitization, because of convergence of noxious stimulus from more than one organ in the pelvis. This cross-sensitization and pelvic crosstalk could be the reason why there are bowel symptoms in this patient as well, and the dietary alteration leads to improvement in some of this patient. The ICBPS without Herner lesion is also been put forward as a potential somatoform disorder because of psychological factors such as childhood relation trauma, sexual abuses, or a functional somatic syndrome. These patients usually retain their bladder capacity and symptoms frequently extend beyond the bladder. The last mechanism may be genetic. However, the study has been confusing to say the least, because the studies in twins and first-degree relatives from Sweden were suggested, but they did not prove the role of genetics, as well as gene expression profiles and the cells cultured from these patients, and the chromosome studies have been inconclusive as well. So the familial predisposition as seen in some patients may be due to epigenetic reprogramming rather than the core genetic defect itself. So to conclude, I'd like to say that the recent growing evidence has changed the current thinking of the pathophysiology of this condition. Those with hernial lesion is an inflammatory disease, potentially associated with immune response and infection, and should be considered a distinct form, as these have different prognosis and treatment modalities are available. And those without the hernial lesion is a non-inflammatory disorder, and this is often associated with systemic hypersensitivity, potentially due to neurophysiological and endocrinal abnormality. Thank you.
Thank you, Dr. Manish, for making this complex topic so simple to understand. I'm sure there will be lots of questions from the participants for you, but we'll take it towards the end of the presentation. So without wasting much time, so I'll request next presenter, Dr. Sanjay Pandey, to highlight on clinical approaches to interstitial cystitis, because this is the most important topic, because we need to have a high level of index of, we should have a high level of index of suspicion, because unless we know about this disease, we are not going to find it. Dr. Sanjay, please. Sir, your mic is mute. So
sorry about that. Am I audible and visible?
Perfectly fine, sir. Go ahead.
My erstwhile colleague just did talk about all this. So the clinical aspect of what he did talk about was this. The patient in question, more common female than male, continues to complain about this and agony and continues to be living with it. She comes to our clinic and discusses about these things and continues to be changing city to city, doctor to doctor, clinician to clinician, and living with agony of pain on bladder filling, gross frequency urgency, which is sometimes a painful urgency, progression which happens with various issues, and flares which can possibly give her a trouble. The urgency, urge incontinence, another kind of a domain that she goes through. So pain, discomfort, all down deep in the pelvis is something that she goes through. I did hear about the vicious cycle that is happening around with multiple pathways that are activated around, which actually takes the bladder insult to different levels, which gives all those discomfort levels, which will be coming later on the evaluation part. But clinically, we are looking at something happening deep inside, which is troubling her, and she or he is in agony. That entire vicious cycle of IC bladder pain syndrome is very unique and difficult, because people have got variable presentations, very vague presentation to complete flare. And this has been happening at very different age groups. We know that females have more common presentation, more preponderance than males. And we also look at it's a progressive and disabling disease. What was in 2010 will not be in 2020. So there are modalities to treat, there are modalities to evaluate, but who are we? So when we look at, we as clinicians need to take this forward to the highest possible level. In the past, we did not have all that which we have today. We have guidelines, we have multidisciplinary teams, we have multimodal therapies, but to identify that, we need to identify the individual. Now, I gather that men also have this very important issue, which we incorrectly diagnose sometimes as prostatodynia and non-bacterial prostatitis. Many of the early stages could be very subtle, and as rightly said by Dr. Pawan, there's been a very high degree of suspicion to pick up these patients and separate this from that, which means flares could not only be a UTI flare, but it could be a flare of the disease. We should look at not landing on the slippery slope of these patients being treated on the same pattern. Exacerbations happen on these patients. Therefore, it's quite a wavering kind of a phenomena that patients go to. They go through the stress. What they speak out is more of a stress, and we need to go deep into the history taking and evaluation to pick up things around. We have many a times laughed at these patients, said that what you talk about your food is possibly not right. And that is not true. They talk about those food which exacerbate and worsen the symptoms. And we know that now in IC bladder pain syndrome, a food diary or a food important aspect of food issues. Finally, we need to know that this is not an acute phenomenon. This is a progressive phenomena, a phenomena which is prolonged anything between 3 weeks, 6 weeks, to 3 months and beyond around. So there are clinical correlates which we need to look into. And that's where it is so important to clinically approach these patients. When they complain, we talk to them, we understand their agony, but we also evaluate and look at them. And clinical examination, therefore, is more important than what has been done. I'm just trying to put some pictures of looking at urgency frequency symptoms could be happening because of bladder, but this also could happen because of pelvic muscle spasms. Dyspareunia, which can happen as a level of the bladder pain or bladder inflammation deep inside, gross cystitis, can have a vulval pathology and a pelvic muscle spasm. Pelvic pain can happen due to bladder, vulval, pelvic spasticity, endometriosis, and so many organ crosstalk. So there are many clinical correlates to this entire subject. For example, how does one classify those patients, males or females, to a gynecology clinic or to a urology clinic? So let's look at more preponderant women who visit a urogynecologist clinic or a gynecologist clinic, or your and my clinic. All those patients who come to our clinic could be having pelvic pain, pressure, or discomfort. And we start suspecting about umpteen number of overlapping phenomena which happens around. And when we look at the next scenario of patients who in that domain have got urgency, force frequency, and dysuria, then we're looking at persons possibly could be having target diseases. In other words, when we go back home tomorrow and look at our patients who were refractory to a therapy that me or my colleagues attempted in the past in various cities, hospitals, or in various fraternities, and we look at the new patients around, then we really wake up that there is something which is missing the boat. In other words, the clinical workup on these patients is not as straightforward as 1 + 1 = 2. We got to understand them more thoroughly. Obviously, there has to be huge amount of empathy on these patients because they have already seen many doctors. They have attempted many attempts of therapy which has failed around. So to look at our refractory patients who have been treated for recurrent UTI, chronic pelvic pain, overactive bladder treatment failures, and concurrent endometriosis not responding to therapies that we have given as gynecologists, or the new patients who now come up with that domain of being a woman or a man, having urgency, painful frequency, pain, dyspareunia, and clinical examination pointing to it, are those patients whom we need to consider. And that's what we have actually included in our churning that happened around finally to bring about these guidelines. The Gibbs definition of ICD-BPS stands extremely tall, talking about which patient would I suspect and label as this or that. So pain or discomfort in the lower abdomen or in the urogenital area of more than 3 months duration, which is worst on bladder filling, relieved partly or completely on bladder emptying, along with one or more lower urinary tract symptoms of frequency, urgency, nocturia, which could even be painful, with or without standard stigmata on cystoscopy, and provided another discernible pathology like the one which could be causing similar symptoms has been excluded. We are almost close to having a positive definition and a proactive way of picking these patients up. So just to give you that, clinical definitions are what we need to look at. Imagine tomorrow morning when this landmark Noss and Gibbs meeting is over and we have got 4 symptoms patients who actually come and see you for the first time in hope that you out of the million doctors that they think about have the expertise to look at. Let's look at these individuals and understand how they go through agony and then the clinical workup. So a journalist in Hyderabad talks about gross frequency of urination by day and night. And sadly, she could be treated as an overactive bladder. She has got burning sensations in the lower zone and somebody would think it to be a UTI. She has got dyspareunia and therefore is so much socially and otherwise mentally disturbed. She has regular menstrual periods, may not be seeing her gynecologist later, but has been treated as recurrent urinary tract infection over the past 2 years with our colleagues in urology and in gynecology and has no relief. Therefore, if that is the kind of patient who's presenting with the kind of pathology that our colleague did talk about, we're going to see a patient possibly who has seen her doctor only on flare-ups. Otherwise, she has been living a life of agony with all those things, which is a part of it. Let's travel to Nepal and look at 29 years young lady who has learned a force frequency. She is forcing herself to go to the washroom for the last 3 years because there is a reason that she has to go to washroom more frequently. And this is a progressive phenomenon. So she's forced by lower abdominal discomfort to visit a water closet more than 20 times in daytime, according to the frequency volume chart that she presents. She wakes up at few times tonight with discomfort, passes small amounts of urine, has got irregular periods and PCOD, all the more reason to see our gynecology friends, but her urine routines and cultures are normal and she is not a UTI. So she has got all this a syndromic approach where many of the investigations may not pick up much. So it's us clinical to look at, oh, this patient is suffering from something which possibly may not be picked up by evaluation. Let's go back to the capital city of Kathmandu where a 54 years established woman who's a housemaker is suffering from burning sensation in introitus. And it's not because that she has got a UTI. She's a postmenopausal woman. She complains of pain on bladder filling and there is some relief with emptying. She complains of pain on traveling in auto rickshaw and lumpy, bumpy roads and complains of painful urgency. She also gave up sexual activity due to all that which is preceding. She has been treated for endometriosis, which could be coincidental or it could be a parallel thing happening around by the gynecologist. She not got a relief. And then she's going to see you tomorrow morning, Friday, as another the patients around. And we travel to the beautiful city of Dharan, where a 22 years young woman, as young as only 22 and single, talks about commencement of something very classically as UTI that you and I look at. Dysuria, fever, urgency, and hematuria episode, 4 years, obviously post-coital phenomena that she remembers. Her pelvis has been on fire and menstrual periods are haywire. Coitus is uncomfortable thereafter forever and voids day and night and complains of prematuration, pain in the pelvis everywhere. And she's going to see you tomorrow. Pain everywhere, going to the anal verge to vagina. So there are these kind of patients, and these are all real patients who actually has been seen around. So symptoms of that kind, which we have discussed already, are pain, heaviness, and discomfort. And the pain traveling to all locations because of the various neuralgic phenomena, the myofascial bands, the kind of crosstalks happening around, are where we need to approach them clinically. So the clinical approach is by history, and by good clinical physical examination. That tells 80% of our disclosures around. We will evaluate them basic because we need to rule out things which should not be so serious as one we could miss out. And then we go look at advanced, which our colleagues would talk about only if required. Which means the basic clinical approach to anybody would be talking, discussing, evaluating, and letting them go with probably a passion and empathy that you will get well. We will take you forward in a journey with not me alone, but we means a team of our colleagues who will look at your complaints too. A 3-day warding diary tells us everything about it. It talks about the painful frequency and painful urgency. It talks about her frequency and it talks about her systometric bladder capacity. It gives us an idea about the miles that she has traveled in the disease process, which may come a little later. The food diary allows us to identify the flare-up foods. We obviously do a basic evaluation of urine routine, which is midstream urine routine and culture. Gives us an idea that she does not have a UTI. If she has a persistent pyuria with negative cultures, where in this part of the world we talk about sterile pyuria, we want to wake up to genitourinary tuberculosis, possibly a UTI partly treated, or specific cultures required for those microorganisms. If somebody is a smoker or somebody has got persistent microscopic hematuria, a urine cytology would be an important part of the workup in anybody who is in 30s and 60s around. And finally, if I'm a gynecologist and I always have a team of urologists, we look at urology referrals and cystoscopy in accordance to the local protocols, and I look at creating a team. And that's where we is stronger than I, because we all create a team. So the baseline investigations for any lower tract symptom, which is ultrasonography, looking at the upper tract, looking at the bladder, looking at the bladder thickness, the pre and post-ward residue. We look at the patient and the patient's pain and complaint. Where we look at symptom scores, we're looking at attempting to do a clinical phenotyping and segregating patients according to scores. So pain score is a great score for us to finally understand where patient comes back and we understand the reality, the quality of life score. These are all important to identify and classify patients towards proceeding on possibly a journey of treatment, which may be long. Symptom score is for evaluating this patient, understanding whom all will involve on day one in my team. A pain therapist for sure, a gynecologist also for sure. Therefore, multidisciplinary team will come into work while the empathy, follow-up, and response to therapy will be not known by the patient coming and giving us clues on it. Now, we need not really look at biopsy and potassium sensitivity test and urodynamics and biomarkers, etc. as large issues immediately, because they don't come to the foreview on day one. Possibly, there could be reason of urodynamics to be done in a patient who's stable enough and has got refractory OAB symptoms or stress incontinence or warding dysfunction, but that comes a little later as we move forward in the clinical workup of these patients. When we talk about not missing out something, we don't want to miss out a carcinoma in situ, eosinophilic cystitis, and tuberculosis. And the colleagues will, when they talk about cystoscopy, they will say that biopsy would be looking at anything suspicious, but not for anything else. We did talk about this word called diagnosis by exclusion. And when we look at the ESIC guidelines, which have been published by expert consensus, we also look at our colleagues talking about A to Z on that. That means when we are looking at a patient in front and talking history, we are almost ruling out this in my mind in our history and clinical examination. So all of them are already being taken forward. So friends who are gynecologists and urogynecologists, and all of them who can actually take the subject forward, it has been recommended by guidelines, including the GIBS guidelines, that we could take the subject by a clinical scenario, work up at the very basic level, and to go to deeper levels of work, which is not required unless it's a very difficult or a refractory case at the very outset. We may not be getting deep into the body and doing major workup immediately. So, in other words, the clinical workup and approach to a patient with ICBPS is about taking the subject forward with understanding. And I'm sure when we come to these points in due course of time, you also will come to management. So I come to a close because we have all these being discussed around. We are aiming to do good management only when we identify the patient well. And the identification of the patient is well done by approaching to them sequentially or by a teamwork. Many times, I may not be the best person and somebody else in the team may pick up. So as more and more people look into and probably look at various domains of a clinical workup, which could be a pain therapist, a gynecologist, a physiatrist, maybe even a psychiatrist in some situations where it has become a psychosomatic long-standing issue. I see bladder pain syndrome finally will be a workable, treatable by a teamwork, stabilizing, identifying the confounding factors which may have been missed, and looking at those measures and outset which could probably save the bladder. Thank you so much.
Thank you, Dr. Pandey, for highlighting the clinical approach. I'm sure that you perfectly mentioned that the clinical acumen with a high index of suspicion is the key to success. But at the same time, we should not miss that, we should not misdiagnose it, and the proper diagnostic evaluation are also essential before labeling the patient as interstitial cystitis. Now we'll need to move forward with next presentation. So I'll request Dr. Ghanshyam Sigdal to present on the cystoscopy for interstitial cystitis. Dr. Ghanshyam, please. Dr. Ghanshyam, you need to unmute your mic first.
Okay. Are the slides visible?
Yeah, it's visible. So you have to do the F5 or slideshow from the beginning.
So, just good evening, all the esteemed faculties and all the participants. As we are discussing on the disease process, where there is no consensus in the name itself, and there's no consensus regarding the different investigations and the treatments. The cystoscopy, role of cystoscopy in bladder pain syndrome is also not without controversies. So we know lots of scientific communities and organizations, they're working on this entity. So many of them, they recommend cystoscopy with hydrodistension as an initial diagnostic tool for the diagnosis of bladder pain syndrome. Except few of the organizations like American Urological Association, which considers cystoscopy only in certain situations like complicated cases with hematuria, incontinence, and overactive bladder, etc. Similarly, bladder biopsy as a part of initial workup is supported by only few organizations like ISIC and the European Association of Urology. Well, the rest of the organizations throughout the world, they take it to be either optional or they don't recommend it. So why we need a cystoscopy in bladder pain syndrome? We know that cystoscopy has both a diagnostic and a therapeutic value. So if we do a cystoscopy with hydrodistension, we can document the stigmata of bladder pain syndrome like glomerations and Horner lesions. In the meantime, we can rule out many disease conditions which can present as a bladder pain syndrome like carcinoma in situ, tuberculosis, eosinophilic cystitis, and etc. So we can take a biopsy, we can assess the bladder capacity, which probably will guide to us whether the patients will be benefited by doing a therapeutic hydrodistension or not, although it has got its own limited efficacy. So since the patients will be taking under general or regional anesthesia, it can be an opportunity to ablate the Horner lesion by means of different energy sources. And after all, considering all the findings, gross findings in the cystoscopy and the biopsy, we can make an overall prognostic, prognosticate the disease in future. So there are certain rules to have a cystoscopy. And we know that the hydrodistension is an essential part of a diagnostic evaluation if you do a cystoscopy. So normally the rigid cystoscopy is preferred over the flexible cystoscopy because of its better optics, ease in taking multiple biopsies, and a good better channel for the irrigation. The patient has to be taken under some form of anesthesia, either a general anesthesia or a regional anesthesia. Local anesthesia is rarely condemned because the patient is already having a pain, and on top of that, if you are distending the bladder, it will be unbearable. So we do not recommend a local anesthesia. The irrigation height has to be maintained at around 80 centimeters from the symphysis pubis, and we have to see the bladder when it is not fully distended, like we do in a regular cystoscopy, hydrodistension, the duration of distension should be of around 2 to 3 minutes. But if we are taking the patient for a therapeutic hydrodistension, the duration will be up to 8 to 10 minutes. After it's completely distended, we empty the bladder and note the effluent and collect the amount, also measure the amount, and the amount which is measured gives the maximum capacity of the bladder. And if there is a hematuria, especially in the terminal part of the effluent, that indicates that there are lesions which has bled. And normally the bleeding stops by putting a irrigation catheter overnight. Subsequent distension is not done with the maximum capacity for a better visualization of the lesions as well as there should be also.
Hello.
Hello.
Hello. Can somebody please unmute their mic? Somebody who's not a speaker, please unmute. Please mute your mic. Yes.
The lesions,
sorry,
yes, the lesions should be described in a systematic way, and the biopsy should be taken once the hydrodistension is over. We should not take the biopsy in a fully distended bladder or before going for a hydrodistension, because it can lead to a perforation of the bladder. And we need to take at least 3 biopsies from different areas in addition to the biopsy from the lesions. This is how I have picked up from a journal of urology. This is how the documentation has to be made with the diagrams. Now I would like to talk something about the specific lesions like Hunner lesion and glomerulations, which we pick up during cystoscopy. The Hunner lesion prevalence is 5 to 57%. It's a widely variable, because the most important problem in not picking the Hunner lesion is due to the lack of experience of the person who does a cystoscopy. And the Hunner lesion has got a distinct clinical, pathological, and treatment differences. Like the previous speaker, Dr. Manish, also has highlighted that now the trend is towards gradually going towards differentiating a patient from with the Hunner lesion versus non-Hunner lesion. So Hunner lesions, we have to pick up the Hunner lesions not in the fully distended bladder initially, because once it gets fully distended, it might be obscured. These are the few pictures showing the Hunner lesions. Like in A and B, we can see the Hunner lesion. What is the C picture? In the C, we can see post-hydrodistension edematous mucosa, and D is showing the waterfall pattern of the bleeding. Now, glomerulations is given so much of emphasis in NIDDK criteria, but glomerulations are not so specific to the bladder pain syndrome, because it can simply be a reflection of the rupture of the vessels in a previously underfilled bladder. And it can be detected in various conditions like neoplasia, different forms of cystitis, infective radiation or chemical cystitis, and chronic underfilled bladder. These are the few pictures showing the glomerulations and the typical rainfall pattern of bleeding. Remember that if the Hunner lesions, it gets stressed during hydrodistension, it gives rise to a waterfall pattern of bleeding, means the bleeding is more profuse. But if there is a bleeding from the glomerulations, then it gives rise to a rainfall. That means the sparse, it's not so profuse bleeding. Now ISIC has given a cystoscopy classification from grade 0 to grade 5, indicating the severity of the disease. Now, after going through the cystoscopy with hydrodistension and biopsy, again, the ISIC has given a subtyping of the bladder pain syndrome. So it indicates, like, if it is a 3C, that means there is a Hunner lesion in the cystoscopy, and C represents the severely inflamed nature in biopsy. So it is indicated by the two things. Number represents the cystoscopic finding, whereas the letter alphabet represents the biopsy finding. Something about a cystoscopy in therapeutic hydrodistension. It has got a short-term efficacy up to 60%, whereas the efficacy almost becomes 0 by the end of 6 months to 1 year. And it is found to be more effective in patients with Hunner lesion in small capacity bladder. The possible mechanism of action are basically the degeneration of the efferent nerve endings due to a pressure of the distended bladder. So there are again not the different levels of recommendations, and the overall level of evidence for therapeutic hydrodistension is 3 and recommendation is grade C. Now something about narrowband imaging cystoscopy, as we know that in other conditions also, like especially in malignancy also, the chances of picking up the pathology by narrowband imaging is far superior as compared to the white light cystoscopy. And so if we use a narrowband cystoscopy, it may avoid the hydrodistension, and we can pick up the lesion in the early phase. These various pictures showing the narrowband imaging images, you can see that. So it can be a better armamentarium as compared to the white light cystoscopy. Finally, there are certain limitations of the cystoscopy, as you know that it is contraindicated in UTI, pregnancy, past history of perforation of the bladder with hydrodistension, and if the patient is of high anesthetic risk. There are certain complications like hematuria, clot retention, urosepsis, bladder rupture, and bladder necrosis, which is a very rare entity. So to come to a conclusion, although cystoscopy is not widely recommended as an initial diagnostic tool, but anyway, it can provide us an objective evidence for the diagnosis, classification, management, and prognosis of bladder pain syndrome. The standardized diagnostic criteria gives a uniformity and comparability of the studies, which can be documented through cystoscopy. And it can, in the meantime, it can, rule out the dreadful conditions which might present as a bladder pain syndrome and which we might be treating for a long duration before finally it goes into an advanced stage. With this, I would like to conclude my presentation, and I would like to thank NOUS and GIBS for this opportunity. Thank you.
Thank you, Dr. Ghanshyam, for the extensive elaboration of the cystoscopic finding. During your presentations, I found some comments from Dr. Siva Priyadarshi. So I'll request sir to take this forum for a few minutes and highlight about the Horner ulcers, because this is considered as one of the hallmarks of the disease, diagnostic criteria for this disease. So requesting Dr. Siva Priyadarshi to take a few minutes highlighting on this topic.
A very good evening to all of you. I compliment and congratulate Dr. Pawan and his team for taking this initiative. And I'm really feel happy that we are working together, both India and Nepal, both societies. As you said, Dr. Ghanshyam was saying about the Horner's lesion. Cystoscopy is one of the most importantly used just to differentiate between a Horner's IC and a non-Horner's IC. And as he said that it should be seen only in a non-distended bladder, and after distension it disappears, which is probably not true. What we see usually is a scar which has a radiating vessels around, that is a Horner's lesion. And when it gets, the bladder gets distended, there may be a crack or ulceration in that lesion with subsequent bleeding also sometimes. So it won't disappear, but the lesion would crack or ulcerate. Secondly, as I said sometimes you may not see the stigmata on a non-distended bladder. So a diagnostic hydrodistension is also required in these cases, as he has also mentioned in his talk, to produce these stigmata. So not necessarily that you have to see all these stigmata in a non-distended bladder only, without distension. And the third thing was about the therapeutic hydrodistension. 8 to 10 minutes hydrodistension, most of us would agree now that is not required and may be counterproductive or may be dangerous also in some of these patients. So maximum 3 to 5 minutes hydrodistension is quite enough to produce the result. So that was my take on Horner's lesion and all. Yeah. Thank you.
Thank you, Dr. Sivam. So now we would like to move to the next presentation by Dr. Rajesh Taneja, who is chairman of the GIBS, and I'm sure under his leadership, this particular disease will have lots of treatment options in our region. So because many people will become more aware about these conditions, and they will have lots of discussions in the platforms. I'm sure these conditions need to be discussed at least once in our National Congress. So we, in this present context, we'll make sure that these interstitial cystitis bladder pain syndromes, which they're rampant in our community, need to be discussed during our national meeting as well. So Dr. Rajesh Taneja, please.
Yeah, thank you. Thank you, everybody. And thank you, Dr. Pavan. This has been a wonderful session. And as I said, I'm very happy to see so many people talking about interstitial cystitis and talking so well about it. And they're so well informed. I think my dream of starting this organization has really bore fruit. And that is, you cannot have more joy than this. Anyway, I will start with my presentation. It is a video with an audio background. So this is a brief atlas of cystoscopy, and it starts now.
In bladder pain syndrome, interstitial cystitis. Cystoscopy must be done as a comfortable procedure, preferably under general anesthesia. The only definitive diagnostic criterion for BPSIC is presence of Hunner's lesions. Non-specific findings commonly encountered are glomerulations, mucosal cracks, draining of blood, Hunner's lesions. Typically stellate-shaped structures on the distensible part of bladder. Rest of the bladder is usually having normal mucosa except in late, end-stage bladders. The center of the lesion has a stellate shape with linear extensions which appear pale ischemic zone. Capillaries arranged in atypical parallel array seem to be radiating at right angles from this pale area. From a distance they appear to be a patch of erythema, grayish, slough at the summit of the pale stellate area. Are there any stages of Hunner's lesions which corresponds to the phase of progression of disease? This is a typical Hunner's lesion in an early disease where the rest of the bladder is healthy and appears to be compliant and well distensible. This is a little longer standing disease. Note that the lesions are more erythematous and there appears to be tendency for confluence. Another case of early Hunner's lesion. Note that after hydrodistension, draining of blood is occurring only from the center of the Hunner's lesion and nowhere else in the bladder. This is characteristic of early disease. This is a case of 3 years duration. Note the characteristic morphology and multiplicity of Hunner's lesions. Note that one lesion is close to the trigone on right side. The cracking of the pale ischemic central zone upon hydrodistension is clearly visible. After hydrodistension, the lesions are being electroablated using a ball electrode. Long-standing disease with diffuse mucosal edema and small capacity bladder. Hydrodistension and electroablation has been done. Note: the central cracking of the lesion upon hydrodistension. The rest of bladder doesn't show any cracking or bleeding. This case depicts non-specific glomerulations which are diffusely occupying the distensible part of bladder. Note that this is non-specific finding and is not diagnostic of BPS IC. This is a long-standing case with rigid subcervicales upon hydrodistension. The presence of typical Hunner's lesion is diagnostic. Note that draining of blood is only from the Hunner's lesion. Long-standing case with multiple Hunner's lesion fibrotic bladder. Note the appearance of Hunner's lesions and compare them with the early cases depicted before in this video. This is a case of aggressive disease. The Hunner's lesions were treated few weeks ago and the patient had recurrence of symptoms within weeks. The partly healed Hunner's lesions are visible. Note that upon hydrodistension, only the areas with Hunner's lesions bleed while rest of mucosa is simply inflamed. The patient had been treated with hydrodistension and ablation of Hunner's lesions with good response for over 2 years. This cystoscopy was done for relapse of symptoms. Note the central cracking. The science of BPS IC is evolving. Thank you.
Hello. Hello. I hope the presentation was okay.
Yes, sir. Thank you very much, sir. Thank you, Dr. Rajesh Taneja, for the well-prepared and informative video on the cystoscopic description of interstitial cystitis. The pathology is well described, sir, and it's well characterized. I found it more informative than in any textbook that I read. Because the lesion characteristics and everything is described so well. So I think it is treasure that we found the treasure today in this platform. Thank you, Dr. Rajesh. So there might be many questions.
For the time.
Yeah.
Yeah.
So now I will request Dr. Amita Jain to present on the treatment aspect of this disease. And I will also request Dr. Rajesh to moderate the case-based discussion and the question-answer session. After this presentation, we are going to have a small 10-15 minutes question-answer sessions. So all the panelists will be involved, and I'll request Dr. Rajesh to take over from me and continue the program. Thank you. Dr. Amita, it's to you.
So can you see my slides?
Yes, fine, it's fine.
So I'm very thankful to the organizers for giving me this opportunity to speak upon very important aspect of ICBPS, that is the treatment. And as with other diseases, it will include three parts like conservative management, pharmacological treatment, and surgical options. So starting with the conservative one, there are many strategies. I'm going to cover one by one. The good part is that overall improvement could be up to 50%. Sometimes if you are combining the stress reduction techniques, then the improvement could reach up to 80%. And it should not be only the first part of the management, it should be the integral part of every level of management, starting with the patient education and counseling. So once you're disclosing the diagnosis to the patient, it's your prime duty to explain what happens in IC and what is the difference from normal bladder function. And next expectation would be whether there would be a permanent cure or not. So you have to educate them that, like other chronic diseases, diabetes, hypertension, there is no permanent cure, but yeah, with the early adequate treatment, they can have a good period of remission, and the disease can come back, and it is possible the treatment which was working will not work later on. So that's why you have to tell them all kinds of treatments available with all the risk and benefits of the treatments, so that they should not feel hopeless that there is no treatment if one is failing. Now coming to bladder retraining. So sometimes these patients start adopting their own coping mechanism, like drinking less or avoiding public toilets, thinking that it's a recurrent UTI. So you have to educate them that it's not going to help, because drinking less will cause more concentrated urine, which would be more irritant to the bladder, and also a prolonged postponement of the voiding can cause aggravation of pain. So these things should be avoided. And also active pelvic floor exercise, because already because of pain there could be pelvic floor spasm, and these exercises, the Kegels, can precipitate voiding dysfunction. Rather they should do some kind of relaxation exercise or stretching exercises, and also they should adopt some kind of stress reduction techniques like meditation or yoga. And you can also introduce these patients to some dedicated patient support groups we already have in India, and we can share the numbers. Already Dr. Sanjay Pade described those groups. And coming to the dietary modification, though there are some controversial opinions for this, but we all agree that more than 90% of the patient will show in their history that there is some association with food items, though there is long list of foods which has been given from the Western world, but we as Asian differ in our dietary habits. So it would be a good idea to ask your patient to choose from their food list by their own that what food items can cause problem, and then they have to avoid those food items for a while, say for a few weeks to few months. Once they are doing good, then they should start those food items one by one. So say they have taken one, and then they have to wait for 3 days. If there is no recurrence of symptoms, everything is all right, then they can continue having that. But if there is a problem, then they should blacklist that food, and they should avoid in future if it's causing problem. Most common food items which has been seen to cause aggravation of things are caffeine in any form, like not only tea, coffee, even the caffeinated drinks, Coke, Pepsi, or chocolates, dark chocolates, or chocolate ice creams, alcohol, and also the citrus fruits like lemon, orange, apple, pineapple, strong spices, red, green chili, and black pepper, alcohol in any form, or artificial sweeteners, and sometimes some milk products also, especially if old sour curd is there. The first and foremost expectation of the patient would be from you that there should be pain relief, immediate pain relief. So it starts with some mildest analgesic with the lowest dose like paracetamol and brufen. If it's not working, then you can try some mild opioid like tramadol. If it's not working, you can escalate the dose, but if rare refractory pain is there, then probably it's a good idea to refer these patients to dedicated pain clinics. There are some kind of physical therapies also, like if you're able to figure out the trigger points at the time of examination, then either you can release or you can make patient understand how to do the massage or something. For that, it's sometimes causes a great improvement. Otherwise, you might have to might require electrical stimulation, TENS kind of therapies. At our part, we have a specialist for that, like physiatrists, so we can refer those patients to them. Also, there is a good idea to, you can also do direct injection of trigger points with local anesthetics with or without glucocorticoids, but there's no any strong evidence for that. Acupuncture, actually this has a very promising results through many RCTs recently, and that's why it has been included in many guidelines and textbooks, and I'm sure at your part you must be having experts for that. Coming to the specific treatment, so we have already discussed the pathophysiogenesis of the disease. So drugs can work at different levels, like if epithelial damage is there, then gag-like therapies to heal that epithelium, like oral pentosan or intravesical heparin can work. If already damage is causing potassium leak and irritation of the nerves, then probably those medication which inhibit neurological activity, like amitriptyline or pregabalin or gabapentin can work. If there is activation of C fibers with mast cell release and histamine is there, then antihistaminic medications like hydroxyzine can work. So coming to the dose, always start with the lowest dose, like amitriptyline with 10 milligram. I always ask my patients to take it 2-3 hours before sleep to avoid hangover next day, because the side effects could be drowsiness, even palpitation, dry mouth could be there. If constipation is already, then probably it would be a good practice to give something for constipation beforehand. If patient is able to tolerate the medication but not full relief, then you can gradually escalate the dose to 25 mg OD to BD and even TDS. And the second drug is hydroxyzine. So it is a very useful drug in those patients who are having history of allergies like urticaria or bronchitis. Start with the lowest dose, 25 mg. Otherwise, you can increase up to 75 mg per day, but you have to be very cautious in elderly population because of the side effect of drowsiness and confusion. The pentosan polysulfate, few words for that, because it's the only FDA approved oral medication, and we know that it's a biomedicine made from some bark of some German tree, so it should be always kept in cool, dry place, and the dosing is very specific, 100 milligram 3 times a day, 1 hour before or 2 hours after meals. So it's very important, should be clubbed with the food, because otherwise it will not have a good result. And the duration of therapy should be at least 3 months, because it's a slow working medication. If you are giving for the short duration of say 10 to 20 days, it will not give results. So that's the reason some of the studies have not shown the promising results, and even some guidelines have stated that it's not good, it's as good as placebo, which is not correct. We have seen very, very good response in many of the patients, though there are some side effects, but these are usually mild, nausea, diarrhea, and hair loss is usually reversible. Other medications could be azathioprine or cyclosporine. Cyclosporine is especially useful in those patients who are having active Hunner's disease. Coming to intravesical treatment, once the oral medication is not working or having a lot of side effects, then you can instill the medication directly into the target organ with a maximum response and without systemic absorption, so there would be least side effects. But it could have disadvantages, like it's invasive, you are introducing a catheter, so it can cause aggravate urethral pain, and also there is a small risk of infection. These are the commercially available intravesical agents. At our place, we are only having heparin. The DMSO, dimethyl sulfoxide, is of industrial use only. AUA, the American Urological Guidelines, have only recommended these 3 agents, dimethyl sulfoxide, heparin, and lidocaine. We usually use combination, and you can see the publication of Dr. Taneja, and his cocktail includes hydrocortisone 200 milligram with heparin 25,000 units in 40 ml saline. Myself, I use this combination. The dose of heparin range from 25,000 to 40,000 depending on the severity of the patient symptoms, combined with bupivacaine 0.5%, sodium bicarbonate 7.5%, and dexamethasone 8 mg. We usually give it at an interval of 1 to 2 weeks for total 6 times. Rationale for this cocktail regime is that because the gag substitutes work slowly, so we combine with some kind of local anesthetic to give an immediate relief in pain, and alkalization increases the potentiality of the local anesthetic. Preliminary results of my data of around 676 patients, which I kept for 2 years, is very good. More than 50% response, but no response was only with 11% of the patient. There are some tips for doing these intravesical installation. If you are relying on some technician or nurse, then you have to tell that, ask patient, hello, ask patient to come having a good breakfast, because it's a good habit not to eat something during the installation time, because they will drink a lot, then it will fill the bladder fast, and they won't be able to hold the medication for a long period. Also introduce 10 to 15 minutes before some kind of xylocaine or some kind of local anesthetic jelly, so that they will not have pain during insertion, and use the smallest caliber catheter like 8 French pediatric feeding tube, and don't insert beyond bladder once the urine is cupping stop, because otherwise it can touch the various parts of the bladder wall and can aggravate pain later on. I'm not going to touch the cystoscopy part because it has already been beautifully covered by 2 previous speakers, so I'm skipping this part. Coming to the last resort, that is the invasive therapies. It could be injecting botulinum toxin into the bladder, or neuromodulation, or substitution, cystoplasty, or urinary diversion, or cystectomy. So the few word about that, it should be the last resort, because because of active Hunner's disease, a lot of ulcers are there, and it has led to the contracture of the bladder. Then only you have to consider these kinds of things, and don't do partial cystectomy. It's a better idea to do the whole cystectomy or urinary diversion, because if there would be a part of a bladder which is left, it can have recurrence of the disease and can cause problem. Even you have to be very cautious with those patients who have developed central sensitization or are having associated chronic pelvic pain, because all their symptoms will not go with even with these kinds of major surgeries, which are having many other side effects. Coming to the BPS, if it is occurring in pregnancy, only 2 things are considered safe. One is oral amitriptyline, and second is intravesical heparin. DMSO can be given pre-pregnancy, but after pregnancy you have to avoid, because it is having a teratogenic effect. Now we know that there are so many treatment modalities available, but we still lack data. So I will ask you people even to keep your data, and we can collaborate to maintain some kind of randomized control trial so that we can help our own Asian patients. There are many guidelines which has come up time to time, from AUA in 2014 to CUA, that is Canadian Urological Association guideline in 2016, and they beautifully divided the patient based on the symptoms in various phenotypes, and in this way they were able to specify the treatments also. We also recently in 2017 have issued our own guidelines, GIPS guidelines, and recently it was updated also, and it is more relevant for the Asian patients. So my take-home message is that yes, if a patient is coming to the early stage, as we have described in our guidelines, you can follow this stepwise approach. Start with oral non-specific medication, not working, then specific oral medications. Next would be diagnostic cystoscopy with or without hydrodistension, and you can ablate the Hunner's ulcer at the same sitting. But if it is not working, intravesical treatment, and last resort would be invasive therapy. But if patient is coming to advanced stage, it's not that you have to start with the first treatment. You can start the advanced treatment, or you can combine 2-3 treatments together. You have to individualize the treatment, and it would be a better idea to phenotypically decide the patient's treatment, and in order to achieve the maximum response. And if the multimodal therapy is not working in a patient, then you should rethink about the diagnosis, and you should evaluate that patient further. And the last thing is that always avoid long-term antibiotics, oral steroids, or long duration high pressure hydrodistension or intravesical BCG in these patients. So with this, I think I have justified the treatment part of this disease. Thank you so much. Hello.
Thank you, Dr. Amita. You did a wonderful job. And I think we are ready for the next session. But I do not have too many questions, so I decided to talk about few things myself. The first thing that I want to talk is that, of course, we are having such a wonderful webinar, and that is because the interest is rising, which is very important. Because for the diagnosis, if your level of suspicion is high, if your suspicious index is high, the diagnosis becomes clear, because you have to make a diagnosis out of almost nothing. It is making a diagnosis in thin air. So I will just point out few things which have been missed in the whole of the scenario, which I wanted to talk about. One is, of course, you need to phenotype your patients. There will be patients, as my previous speaker talked about, in etiopathogenesis. So there are various etiopathogenetic pathways, and it is a heterogeneous entity. So you need to phenotype which patient belongs to which category. For example, some patients will have Hunner's lesions, others will not have Hunner's lesions. Some patients may have no bladder pathology at all. So that means there may be some neuropathic pains. There, up to 85% of these patients may have dysfunctional voiding. So dysfunctional voiding can cause bladder pain. And the point is that if you do a cystoscopy, you may find absolutely fine. And all you need to do is to find out if they have an overactive pelvic floor, which can be done by a good pelvic examination. So you need to phenotype and then progress further. The other is, of course, if you find a person with a tight pelvic floor, you subject them to good physiotherapy. The problem with physiotherapy is that if you send it for physiotherapy for pelvis, they give them pelvic floor strengthening exercises, which is absolutely opposite to what is required. So they will increase the symptoms rather than decreasing the symptoms. So we need to tell our physiotherapists to prescribe pelvic floor relaxation, because most of the times patients come back with Kegel exercises, which increase the symptoms. So that is very important. So have a dedicated physiotherapist, teach your physiotherapist. Then, of course, we have for the basic practitioners, I wrote a book on interstitial cystitis in 2014. It is readily available. If somebody wants and cannot have it, can just send me a message. I'll see, or BP can organize that. The other is, last year we were one of the first ones in the world to have local diet book. Like we have got an Indian diet book for our part of the world for interstitial cystitis, bladder pain syndrome. So because our diet is different from Europeans, our problem was that our patients would come and ask about diet, and when they go back to web, they will find things which they are not eating anyway. So we had to compile a book on that, and that is also available. Regarding oral pentosan polysulfate, as Dr. Amita has rightly mentioned, that it is controversial. It is not controversial. I have just reviewed all the studies while I was in the lockdown, and I realized that in the studies in which cystoscopic findings were supposed to be good, included in the inclusion criteria of the study, pentosan polysulfate worked in all of them. It did not work in the studies where cystoscopy was not supposed to be a part of inclusion criteria, which means that they collected a lot of other heterogeneous group of patients, and then they gave them pentosan and found that it is not working. So you need to select out your patients. You just don't keep giving pentosan polysulfate to everybody. So your diagnosis has to be important. If your diagnosis is correct, it is likely, I'm not saying it will, it is likely to work. So we cannot write off a molecule like pentosan polysulfate. The problem is that there is one study published by Curtis Neal in 2015, because of which the whole thing changed. But the same group had published in 2005 and had given kudos to pentosan polysulfate with a result of more than 65-67%. So in 10 years, the molecule giving result for 67% has become a molecule giving result which is not acceptable. So what has happened in 10 years? Is a temporal profile of a molecule globally changing the pharmacotherapy? I don't know. So what I found was, the reason was that the study they published in 2005, they had strict criteria of cystoscopy included in their inclusion criteria, which was not there in the 2015 study. So that makes a big difference. Regarding one more thing I would like to say, that we need to have a kind of clinical scoring system. We have the ICSI O'Leary SAND score, and but we can have our own systems. I have one of them. If you want, you can accept it. So I see that there are not many questions, and I would like to then go ahead and ask about the next speaker. So the next, yes, Dr. Pawan.
Yes, sir. There was few concern regarding the duration of hydrodistension and the proper technique. I think our residents also need to tell it properly. So I think Dr. Apul Goel, so if he's there, yeah, I saw him.
Yes, yes.
So,
yes, he's there. He's very much there, and he's going to be part of the panel.
Yeah.
And he's smiling away.
Yes. So can you highlight, sir, about what's the exact duration, how long it should be done, and what's the proper technique? So your mic is mute, so please.
So as Dr. Shivam was saying, actually hydrodistension and cystoscopy, all these are, sort of controversial. And as was discussed, there's no atlas actually of Hunner's lesion, because there's lots of emphasis of whether we need to differentiate between Hunner's disease and the non-Hunner's bladder pain syndrome category. So actually there's no atlas. So what they say is that it has to be in a non-distended bladder. The second point that you were asking was how long you need to distend the bladder. So I think, as Dr. Shivam, I'll agree with him. I think 2 to 3 minutes, what he said, seems to be appropriate. I'm not sure what Dr. Taneja will like to add on this.
You actually summarized everything. See, there is a difference between hydrodistension and hydrodilatation. Initially, the confusion has arisen because initially it was 8 minutes. So 8 minutes, if you distend beyond 80 centimeters, you're going to actually kill the detrusor, because you're going to go beyond the diastolic pressure. You're going to cause ischemia of the detrusor, and the detrusor can get paralyzed temporarily, or in certain cases, quite substantially, and the recovery may not be as good. So it was decided to do hydrodistension rather than hydrodilatation. So if you need to distend, the aim of distension is to disrupt the nerve endings in the submucosa. That you need only for 2 minutes. 2 minutes is good enough to do that. The idea is to disrupt the nerve endings and kill the pain circuit, because it is a neuropathic inflammation, which means pain causes inflammation. In most of the cases, it is inflammation that causes pain. You get hit, you get inflammation, it causes pain. No, in this, it is the pain which causes inflammation. So if you do a hydrodistension, you kill the nerve endings which are causing pain, and the pain subsides, and the inflammatory cycle is cut short. So that is the idea of hydrodistension, apart from increasing. Yes, Dr. Apul.
The latest edition of Campbell, they also mention about 2 minutes only.
That's right. No, initially it was 8 minutes in most of the books, including the NIDDK trials.
So now it is for 1 to 2 minutes.
Yeah, that's good enough. That's good enough. So if there is nothing else, we can move on to the presentation for the case discussion. So I invite the panelists. My co-panelists are Professor Shivam Priyadarshi, Professor Apul Goel, Dr. Amita Jain, and I invite our master, Dr. Sujit Podial, the quiz master, who is going to start and take over the stage. Please, Professor Sujit, over to you.
Dr. Sujit, your mic is mute. Yeah, thank you.
So good evening, everyone.
Hello, good evening. We are there with you.
So I am thankful to Naus and Gibbs for letting me be a part of the program and also be a moderator of this session. So we have a team of esteemed panelists. So they will be enlightening us and demystify this so-called mysterious syndrome. So without any much to do, I would like to start with the case. So coming to the first case, she's 28 years female with lower urinary tract symptoms with frequency deteriorating for 6 weeks, currently voiding every 30 to 60 minutes. She has nocturia 3 to 4 times. She also gives history of severe suprapubic discomfort compelling her to void regularly. She gives history of recurrent lower tract symptoms for 15 months and for which she has received multiple antibiotics, anticholinergics without any relief. She claims that her urine culture was always negative and she is currently taking NSAIDs for pain but without any complete sense of relief. So she says her voiding is satisfactory, but she has difficulty voiding during dysuria. She gives history of dyspareunia, no hematuria, no urinary incontinence, gives history of intermittent headache, relieved by paracetamol without any pain at other sides of the body. She gives history of constipation, but now relieved with change in diet, no history of vaginal discharge. She is regularly menstruating, but gives history of suprapubic pain, which increases few days prior to menses. There is no significant past history, medical illness, or allergy. So I'd like to start with Dr. Rajesh. So what inference can we get from this history and what further history we need to ask?
Yeah, I think since Dr. Amita is there, I would pass on this question to Dr. Amita, please.
Okay, sure.
So I can see that the history patient is very specifically saying that it's a suprapubic discomfort, which is compelling her to void. So that's a differentiating feature because the urgency, we have to ask patient the urgency or the thing which she is getting is not the fear of leak. She is going for the void because she is having discomfort, which is also relevant in the evident in the history. So that is the differentiating feature from overactive bladder. The most common diagnosis which is made for these of the symptoms is recurrent UTI. So we have seen that urine cultures are negative, so it's ruling out the UTI. And the thing on the next slide, you have shown the menstrual history there, where she is saying that there is suprapubic pain which increases just prior to menses. So that could be a differential diagnosis. This patient should be further evaluated for endometriosis, which is a differential diagnosis, and for that you need a good clinical examination, pelvic examination, and ultrasound of pelvis to rule out endometriosis. So these are the things I would like to highlight, and the examination part will also give you idea any kind of trigger points, pelvic floor spasm or something which is causing aggravation of thing, because these patients are prone to develop voiding dysfunction later on. So that's my view.
So thank you, Dr.
So
Amita.
I will add on something. Yeah.
Okay, thank you.
So,
okay, sure, sir.
So the simple question that I would have asked is, when you wake up from sleep, is it the pain that is causing you to wake up, or is it the bladder sensation which is causing you to wake up? Because if it is pain, then we know that yes, there is a problem. Another thing is, of course, when Dr. Amita, that is why I put it to Dr. Amita, because a change with a menstrual cycle means that there could be something else sitting there, which could be an endometriosis. Anything else, Dr. Goel, you want to add?
No, I think Dr. Amita has, said everything. And you need to keep endometriosis in mind, because as urologists, we often miss this thing. So, because as a gynecologist, so she picked up, endometriosis, which has to be always kept in mind. Otherwise, this lady, except for the fact that she looks a bit young, actually. So, although even this condition is described in children, but otherwise everything falls into into this bladder pain syndrome category.
Yes, sir. So the history gives clue towards bladder pain syndrome, but we have to rule out endometriosis. So to complete this history, I would like to add that she gives history of generalized weakness, loss of appetite and weight, She is insomniac, no interest in work. She is housewife, married for 5 years with 1 child. Her husband works in Dubai. She has received high school education. There is no significant family history, and she is from low middle class family. So does this history adds up to anything? So Dr. Rajesh.
Yeah.
We
So
need to take
when you say insomnia, I need to understand, is it truly a nocturia or a nocturia because of insomnia? So the question that I would ask is, okay, when you wake up from sleep, you go to pass urine, you come back, do you go off to sleep immediately? If you're not sleeping and you're tossing in bed, you've got nothing else to do, you just walk up to the washroom, and that is counted as nocturia. So one has to be very careful when you talk of insomnia with nocturia together.
So yes, sir.
I want to add one thing.
And loss of weight has to be accounted for. Never in ICBPS you will have a loss of weight unless there is a functional overlay and there is a functional problem of anorexia, which we need to assess.
So we have a lot of differential diagnosis.
One thing I want to add that we can see the lot of stress factor. We can see a lot of stress factor, like she's having insomnia. That's that could be because of the disease, but she has to care, bear the child. Her husband is away, and so there could be, we have seen that stress induces the flares. So that could be the reason for her recurrent symptoms. So that could be the one thing, because probably she is not having the diagnosis till now. She was diagnosed as recurrent UTI, so she must be having that stress also, that she is not having the diagnosis. So sometimes these things also aggravate the scenario.
So, yes, sir. So whenever we are dealing with chronic pain, so we have to deal with we have to dig into the psychosocial aspect of the person as well. So these are the DDs. So we have ruled out most of the differential diagnosis. So any comment on this differential diagnosis, Dr. Kapul?
So I think you have enumerated all possible differential diagnosis here, and as you have highlighted, because although the condition is bladder pain syndrome, but if you see 75% of these patients will have associated symptoms. Yes. Only bladder-centric disease is only 20 to 25%. So as you have mentioned that this lady has other symptoms also, like anxiety and headaches and all those things. So I think she is, falling towards the last differential that you have mentioned, which is the bladder pain syndrome.
So yes, sure. Bladder pain syndrome should be suspected at first, but should be diagnosed at last, after ruling out all the differential diagnosis.
It's a diagnosis of exclusion.
Yes.
Yes, Dr. Shivam, please.
Yes.
Yes.
Thank you. Amongst the history, one of the components of the history was that she has loss of weight and loss of appetite also. So being in this part of the world, we should always rule out a case of genitourinary tuberculosis also.
Yes, yes.
Yes, though these symptoms could be due to psychosomatic also, maybe it's because she has been suffering for so long. So that could be something related with psychological disorder also, but we should rule out genitourinary tuberculosis. The secondly, about endometriosis, typically endometriosis will have pain during menstruation and not just before menstruation, which is quite typical in interstitial cystitis. And patients with cyclic hematuria, which is present in around 20% cases, is probably diagnostic of urinary endometriosis. While diagnosing a case of endometriosis urinary, we have to think that ultrasound and anything else, physical examination, may not pick up endometriosis, urinary endometriosis. So many of the researchers and clinicians have suggested that laparoscopy should be done together with cystoscopy in these patients if you are suspecting endometriosis, because endometrial lesion always starts from the serosal surface, from the peritoneal. So you will have peritoneal lesions and you may not find anything in the bladder itself. Bladder endometriosis usually is presented only when there is a deep infiltrating endometriosis, which is present in some of these cases. And if they present into the lumen of the bladder, then only you will find bladder lesion, which is obvious on ultrasound. So laparoscopic, diagnostic laparoscopy would be required if you want to rule out endometriosis in this.
Yes, sir. So that's the point.
Yes, I will just add on one point that as Professor Shivam has rightly pointed out, that in the late 1900s and 2000s in Europe, there was a trend to do all these hysteroscopy, cystoscopy, laparoscopy for any pelvic pain. But then that was overkill. But what he has just mentioned is absolutely right. If there is any clinical hint that there could be an endometriosis, one should not shy away from doing laparoscopy at the time of cystoscopy.
If I might add something here, because in last one of the conferences I just presented on endometriosis of urinary bladder only, and its relation with interstitial cystitis. I will tell you a few facts. These conditions, both IC-BPS and endometriosis, are considered as evil twins of chronic pelvic pain syndrome. They are described as evil twins, right? And 50 to 80% cases of endometriosis have interstitial cystitis. Patients have 4 times higher chance of having interstitial cystitis if they have endometriosis. 80% of patients of chronic pelvic pain syndrome may have interstitial cystitis. And many of these patients, we do hysterectomy. And after hysterectomy, almost 1/3 of these patients still continue to have pain. And 80% of these patients are thought to be actually interstitial cystitis. So these are a few facts. And almost 2/3 of these patients may have interstitial cystitis and endometriosis coexisting. So they may coexist together. And researchers have also shown that endometriosis can lead to interstitial cystitis. So these are a few facts about these two conditions.
What would be the message, sir? I think the message to gynecologists should be that at the time of treating endometriosis, especially if they are doing a kind of hysterectomy or something, always they should do a cystoscopy to rule out the presence of interstitial cystitis or even the bladder endometriosis. So that should be taken into account. I think this is the message which should be.
Before proceeding with such a radical kind of surgery, we should always think in mind of interstitial cystitis also. Right.
Okay, thank you very much, Dr.
Confined to bladder, yeah.
Okay, so BPS is not a single entity, as we all know. We have been discussing this. And so whenever we deal with bladder pain syndrome, we have to dig into every aspect of the person. We have to rule out systemic diseases, regional pain syndromes, even psychiatric illness. So coming to examination. So her general physical examination was unremarkable. BMI was 21. Abdominal examination revealed mild suprapubic tenderness. Vaginal examination revealed mild anterovaginal tenderness. Her neurological examination was unremarkable and pain score was 7. So Dr. Amita, anything to add on this examination? Excuse me, Dr. Amita.
Okay. So these are the examination findings. So yes, we do my bimanual examination. Can you switch over the slide again?
Okay, okay.
We do the bimanual examination. So that would be the part which is missing here, that we see the pelvic organs by keeping one hand inside the vagina and other on the abdomen. So to know about the endometriosis and any kind of endometriotic cyst in the ovaries and any kind of tenderness, that bimanual examination is important.
Okay.
And for rectal examination also we do in these kinds of patients, because even the endometriosis can affect the rectal part. And of course in history you have to rule out the symptoms also.
Okay, thank you very much, Dr. Amita. So now coming to this frequency volume chart, how important is frequency volume chart? What information can we get from this frequency volume chart? So Dr. Rajesh.
Yeah, this is very important, because a lot of people would come and they will tell you that They have a lot of frequency, but then if you ask them, they will drink 2 liters of water when they wake up. So that is something which needs to be discouraged. So frequency volume chart has to be maintained, because that is going to make life much better. And it is, see, in this case, the maximum volume is 170. And although the patient has not had too much of water, the output is within range 2 liters almost. And if it is 170 ml per void, then perhaps she has a restrictive bladder. Now that means the bladder is not able to hold. If bladder is not able to hold, either it is already inflamed or it is fibrosed. So since it is a short history, I don't expect it to be a fibrosed bladder. But here is the thing where one should consider seriously cystoscopy, because the bladder volume is low. Because one of the clinical indicators that if patient is waking up at night or whenever she has pain suprapubically on full bladder, which gets relieved partly on passing urine, and the capacity is 170, it is likely to be a transmural inflammation of the bladder. This is the inference from this kind of an investigation, which is very simple and cheap. So I would be keen to call it a small capacity bladder, and would like to think about that this patient may require, after we've investigated cystoscopy for a therapeutic purpose. Of course, we will be doing a diagnostic for all, but then this also may require for a therapeutic purpose. So small capacity bladder, if the pain is not there and I have the same thing, then I will think of, you have to look at urine cytology. There may be a small papilloma at the trigone. There may be carcinoma in situ, which can give rise to this kind of frequency, urgency, small capacity volume in the absence of pain. But if the pain is associated, which the patient must certify every time you ask that question, that do you have pain which gets relieved on passing urine or tends to get relieved on passing urine, then of course we consider inflammation. And she's
Thank you,
yeah,
Dr. Rajesh. So we all know frequency volume chart has lots of information to give. And
Dr. Shivam is there. He's pointing his finger.
Yes. Can I speak?
Okay.
Can I speak? Yes. Thank you. This about the frequency volume chart. I would just like to remark that small volume, frequent, and if the volumes are regularly small, then it goes much in favor of interstitial cystitis. We won't say that this is a small capacity bladder, because usually these patients will have functionally small capacity, not actually anatomically small capacity, may not be there. One more thing that we can decipher from this is that the intake is not high intake, right? Sometimes some patients may take a lot of fluids, and which may cause frequency. So his intake is normal, and even then he has frequency. There is no incontinence. So we can rule out overactive bladder. Overactive bladder, again, the frequency will not have, the low volume would not be regular. Sometimes they may have normal capacity urine output, and sometimes they will have low. So these are a few differentiating features by which we can say, suggest that it could be IC or otherwise.
So I would like to move on to other investigations. Our urine routine revealed 2 to 4 pus cells. Urine AFP was sent, which was negative. Urine culture was negative. Ultrasound abdomen was done, which showed normal scan with probe tenderness at suprapubic region, with pre-void urine of 160 ml and post-void urine of 10 ml. And uroflowmetry revealed Qmax of 16 ml per second with volume of 103 ml. So, and comment on these investigations, Dr. Apul?
I think this is okay. This is moving in favor of interstitial cystitis, the bladder pain syndrome. So although urine AFB is not, it is specific but not very sensitive, but still this is the best we have, and culture is negative, so we have ruled out urinary tract infection. Urine RM is, pus cells are almost normal, and ultrasound is also, it's just reconfirming what we saw on the this voiding diary. So I think there's nothing much information that has come up. It's already, this information we were anticipating actually.
So what further investigations would you like to go first?
See, actually, there's no marker, urinary marker for interstitial cystitis. Basically, it's a diagnosis of exclusion. So we have practically excluded all the things. Ultrasound has excluded all. So I don't think we need to investigate her further. And I think we can start therapy.
Okay. So, Dr. Rajesh, any comments, sir?
No, I think this is absolutely fine. And there was a query that I received, the role of urodynamics, because we talked about small capacity bladder. But the point is, in the presence of pain, you know, in another person where there is no other lesion and there is no other symptom, then one may do a urodynamic evaluation complete. But if somebody has pain, then in the presence of pain, the urodynamics becomes more painful and the results are erroneous and cannot be duplicated. So I would not be keen to do urodynamics for a small capacity bladder with pain.
Okay, thank you, sir. So what about clinical symptom scales? There are so many symptom scales. So in clinical practice, which one is better or which one is pertinent? So I'd like to ask this question to Dr. Amita. So Dr. Amita.
Can you hear me?
Please. Yes.
Yes, yes. Now we can.
So we usually using All-Ernie scent indices because it's having all kind of things combined. And actually we have raised in our last GIPS conference that we can include a few things more in that clinical scale. And I think Dr. Taneja got a publication also regarding that aspect. So we are using, but yeah, I am not having details of other scales, so I have no idea. I think Dr. Taneja will give a better answer.
Okay.
Yeah, so I have the bladder pain syndrome scale, which was published in International Urology, which is based in Japan. Now, this scoring system, I decided to incorporate the dyspareunia or the sexual dysfunction and pain during sexual function, and the functional or the psychological impact. And then what I did was I multiplied the pain factor 4 times and nocturia again. So that is a detailed discussion. I don't want to come into it, but then I have that system that is working. If anybody is interested, I can forward it to them. Otherwise, it is available in the International Journal of Urology in the year 2019. I can send a reprint if you can send me a mail. But some kind of scoring must be done. The scoring is important because, very important, because if you have a score and the patient comes back and says, look, doctor, you have treated me, but I'm not better. You ask them to fill the scoring system before they see you. And then you compare that scoring system from the first day that they had come. And then even if the patient doesn't realize, patient has improved. So that gives a positive biofeedback to the patient. So the scoring system works therapeutically. It not only convinces the patient that patient has improved, but also helps the patient. Patient will go back and understand, yes, I have improved. Otherwise, the patient will keep telling you, because pain sometimes is very unquantifiable thing. So the patient will keep saying, "Mereko pehle bhi dard tha, mujhe abhi bhi dard hai." But then the quantification of symptoms has to be there, which helps the patient to understand and go back with a more positive attitude. That's where it works, positive biofeedback. So you can follow any scoring system, whichever you want to follow, you should follow. This is the one that I followed, which has been published. If you want, I can share.
Yes, thank you, sir. So clinical symptom scale, they are essential component of the investigation, and it's necessary for objectification of the progression of the disease. Thank you. So this is the O'Leary Scent score. Not going into detail. So further investigations were also done. Urine PCR was also sent. Urine cytology was also sent. Cystoscopy was also done. So as we have already discussed, these investigations are not necessary. So any comment?
Yes, I would like to. Yeah. Okay. Let Dr. Shivam start off. Yes.
I think if we have we are thinking that she has loss of weight, loss of appetite, and systemic signs and symptoms of chronic disease, then we should do a tuberculosis culture also, AFB culture and PCR also. And about urine cytology, I don't think it is required. Urine cytology would be required only if we have a microscopic hematuria, or because she is female, I don't think she is a smoker. So if she is a chronic smoker or microscopic hematuria, then only we will think of doing a urine cytology. Office cystoscopy, I think because it's a prolonged, she's suffering for a prolonged period. So personally, I think that I would go for a cystoscopy to rule out a non-Hunners from a Hunners kind of ICBPS.
Okay.
So other confusable lesions also, right?
Yes, thank you, sir.
So, Professor Sujit, now I have two problems here. One, I have not been able to explain the cause of weight loss. 5 kg weight loss is significant in a young woman. Unless I am convinced that this is depression and anorexia due to depression, which we need to evaluate.
Yes.
The other is that she has suprapubic pain. Suprapubic pain comes from pelvic organs. What is the status of her large intestine? Sometimes they will have something like an ulcerative colitis, which has not been diagnosed, or maybe a terminal ileum or an ascending colonic Crohn's disease, which can cause malabsorption and reduction in weight. We need to be careful because there can be a crosstalk. So I would be keen to evaluate this person from a different perspective altogether while I'm working on his bladder. So I would need to get a gastroenterologist at this point of time. Let the gastroenterologist define the cause of weight loss. This is very important. Second, I don't recommend an office cystoscopy because office cystoscopy, one, has done under local anesthesia. Two, it is done with flexible cystoscope in most of the places. So when you have an office cystoscopy and the patient has pain when you're causing infusion, irrigation, you cannot see many places. Sometimes you may miss a lesion because patient is moving and it is a moving target and you're trying to find out and the patient is struggling. So I think if we cannot relieve the pain of the patient, we should not give pain to the patient. So although there are centers which will keep continuing to do office cystoscopy under local anesthesia, I'm a strong recommender of cystoscopy under general anesthesia so that you take an opportunity to treat if you find something. And because why is the patient having pain? Because the bladder is getting filled and the pain and the bladder is not able to hold that volume. So you are fighting with the patient. The patient wants the bladder to be empty. You are fighting with the patient to fill the bladder. So that is where the thing is. So when there is, you're working on two opposite ends, and that is a struggle, and you may not be able to do justice to cystoscopy. Dr. Shivam wanted to make a comment.
Okay.
Yes, I wanted to say that cystoscopy is, I would do cystoscopy, not office cystoscopy. I usually don't do office cystoscopy in these patients.
Okay, thank you, sir.
Yeah.
So as we all know, it's
I have one question to Dr. Taneja. So suppose there is no bowel symptoms, her bowel habits are completely regular, even then you can suspect and you will have a GI reference, sir, for this particular patient?
I will tell you, Dr. Amita, who takes responsibility of weight loss. If a patient walks into my chamber and says weight loss, no urinary symptoms or some unrelated stone or anything, the first investigation is we send them to gastroenterologist. It could be a lesion in the stomach, it could be lesion anywhere. They have to find out whether they do a urine for occult blood or whatever. Weight loss is a gastroenterology problem primarily, and it's our responsibility. If I cannot explain, suppose Dr. Shivam does a IVP or CT scan and finds a tuberculosis, I'm very happy. I'm not going to send. But if I don't find that, if I don't find a reason, ICBPS should not cause weight loss. That's the only point I'm trying to make. Then you may need a colleague to help you because you cannot let the patient suffer. we are treating something, but the patient keeps on losing weight, and we miss a lesion that could have been treated.
I totally agree with Dr. Rajesh Taneja. So we need to exclude other diseases, as BPS is a diagnosis of exclusion. So as we have already talked about, so cystoscopy, if done, it should be done under anesthesia, not office cystoscopy. So these are useful for ruling out other bladder lesions. To identify honor lesions, we can do narrow band imaging, assess bladder capacity and reproduce pain, but not in anesthesia. So we can also, there's anesthetic challenge test. So I think Dr. Rajesh Taneja has a comment to make in this anesthetic challenge with alkalinized lidocaine.
That's right. So yes, I used to do that, and I'm still doing it when I'm stuck with a patient. So if I'm not sure whether this patient has a pelvic pain which is related to bladder, whether it is coming from intestine or whether it is coming from the uterus or endometriosis, a simple thing is to put in anesthetic challenge, and that works. This was published in 2007 or maybe 2010 in the European Journal. But this I find very useful.
So thank you, sir. So about diagnostic cystodistension, we have been talking about cystodistension a lot. So I think this is not recommended because it has low specificity for diagnosis. I think we all agree with this, no, sir?
Yes. It is not diagnostic. Yeah.
Yes. So biopsy, when to take biopsy, sir?
Yes, you see, if you do a cystoscopy and you find a lesion, you must biopsy it. That is the primary thing all urologists are taught. If you find something, yes.
For glomerulations, do we need to take biopsy or not?
No. See, you must understand glomerulation is a bleeding spot. So the bleeding spot, and if there are multiple bleeding spots, and the mucosa was normal before you walked in. So when you're evaluating the bladder is being evaluated at partly distended state, and the mucosa is not stretched. So if there is no lesion at say 100 or 150 ml of bladder, then you don't need a biopsy. So what happens when you distend it, and you distend it to say 500 ml, then there are glomerulations and there are cracking and it starts bleeding, then there is no point doing a biopsy, because these are lesions created by you and your hydrodistension.
Okay,
so
thank you,
when I say if you see something at partly filled bladder, you take a biopsy.
Okay, thank you, sir. Thank you for the information. So there is no histology pathognomic for BPS. We all agree with this, and biopsy is done to rule out other bladder lesions. So is there any risk of bladder cancer or upper tract urothelial cancer associated with BPS, sir? Any comment to make?
Yes, I have seen many patients who were treated for pure urgency or pure bladder pain for 2-3 years, and have done cystoscopy because the cytology was suspicious, and I have got urothelial cancer in 3 patients who were being referred to me for intractable frequency of urination. One of them had pain, 2 did not have pain, and I have seen 3 cancers of bladder. So I'm very good. I strongly agree when you did a urine cytology for your patients, because we don't know what they, and one of them was squamous cell carcinoma. So despite cytology being negative, we could pick it up, but then there was urothelial malignancy in 2 cases, and third was squamous cell carcinoma. So I think it is very important. That is why cystoscopy becomes imperative, because if you don't do cystoscopy, you may miss a lesion which was treatable. Yes, Professor Shivam.
First of all, the statement that risk of bladder cancer with BPS, does it mean that BPS may cause bladder cancer? If it means, then it's not, right? We may confuse it with carcinoma in situ sometimes. That has to be ruled out. But I don't think that every patient with these symptoms require a urine cytology. patients with microscopic hematuria, patients who are chronic smokers, or a family history or something like that, then only we need to do a urine cytology. Not every patient who has symptoms related with lower urinary tract symptoms, which seems to be BPS, needs a urine cytology.
So thank you, sir. So we all agree that BPS is not a pre-malignant condition, but it's a case. It may be a case of misdiagnosis. So recent study, Taiwan study, has shown that male BPS patients have 12 times hazard ratio for diagnosis of bladder cancer. Similarly, female has 3.5 times misdiagnosis. So it may be cases of misdiagnosis only. So BPS as it's not a pre-malignant condition, but so we have to be aware whether we are over-diagnosing or under-diagnosing the case. So any comment to make?
Yeah, I think in my last slide, I pointed this out that if you have initiated the treatment of bladder pain syndrome, considering this the diagnosis and the treatment is not responding, then you suspect you should rethink about the diagnosis, and then only further evaluation, even cytology and everything should be done if you are suspecting that that the patient is not responding. That is very important. Even Dr. Shivam is right in that thing that yes, initially you can skip, but if the treatment is not getting response, then probably you should think to avoid these kinds of situations.
Okay. Thank you, Dr. Amita, for the information. So role of urodynamics, we all have been talking about the role of urodynamics. So whenever we come across dysfunctional voiding overactive bladder, urinary incontinence, or neurological conditions in history and physical examination, we have to consider urodynamics. So whenever we do urodynamics, we also need to consider video urodynamics in complex cases. So any comments to make, sir?
No, I think this is fine. You need to choose out your patients. Professor Shivam, any comments?
I just wanted to say that it is not a routine investigation in these patients. Urodynamics would be required in a very subset group of patients where we are confused whether this could be a case of neurogenic bladder or if the patient has some obstructive urinary symptom. Particularly if a male patient, we think that he may be suffering from BPS, we might do with obstructive symptoms, then we might do a urodynamics to rule out any obstructive pathology also. So not every patient would require a urodynamic study.
So if we do urodynamics in these patients, these are the findings. So here you can see normal compliance, no overactivity. So there will be only hypersensitivity. So in this case, the first sensation was at 63 ml, first desire to void at 95 ml, strong desire to void at 118 ml, and maximum capacity 138 ml. So similarly, voiding phase was normal. So I think it didn't add up to our diagnosis.
Right.
Just introduction of our symptoms only.
Yes.
So, Dr. Sujit, I must tell you something. If you see the maximal cystometry capacity is 138 ml, which means it is less than what the patient can hold otherwise.
Yes.
So patient has given a frequency volume chart saying 170 ml, and here the urodynamics says 138 ml. So this proves my point that in the awake state, if the patient has pain, you are trying to fill the bladder and the patient is resisting filling the bladder, and that fight will continue. That's one. Second is, if you look at the production of urine per minute, so the production of urine is per 1 ml per kg per hour, which means almost if there's 60 kg person, it is 1 ml per minute. So when you're doing a urodynamics, so what you're adding is actually 10 ml per second, per minute. 10 ml per minute is what you're irrigating. So which is a very high rate of filling of the bladder. So that is another reason why in awake state, patient with bladder pain syndrome will document a smaller bladder cystis capacity.
Okay, sir. So this is our pressure flow study. So what about other investigations? CT, MCVG, urinary markers, potassium chloride test. Any comments to make, sir?
So let me, come back again. So these are not done actually. These are only done as for urodynamics. Also, if we are stuck, the patient is not improving, you need to rethink about the diagnosis. So, and these urinary markers, they are still not standardized. They are still experimental, and they are only done only when you are doing a clinical trial or something. And potassium chloride test, because it aggravates the symptoms. So, so people avoid it. It was described long back, but because you may aggravate the symptoms, you may induce the pain. So this test is also not done now.
Okay, thank you, Dr. Apu. So this, for initial diagnosis of BPS, these investigations are not necessary. Okay, thank you. So as per AUA guidelines, to conclude our history physical examination and diagnosis. So for simple case of BPS without any incontinence, GI symptoms, signs, hematuria, hysteral pyuria, and gynecological signs and symptoms, so basic assessment is enough, which includes history, frequency volume chart, examination, post-void residual urine, urinalysis, and symptom questionnaire along with pain evaluation. Cytology is needed if there is high risk for bladder cancer. And for advanced diagnosis only, we need to consider urine cytology, imaging, cystoscopy, urodynamics, and these all depend upon the discretion of treating urologist. So any comment to make, sir, in this AUA guidelines?
No, I think this is perfect.
Okay, thank you, sir. So what about phenotyping of BPS? So we have been talking about we need to phenotype BPS. So BPS has been phenotyped by different guidelines, by different association in different ways. So some phenotyped as honor type, non-honor type, some as phenotyped clinically as input system, ASIC, has used cystoscopy, biopsy, some has classified it as pelvic pain only and pelvic pain and beyond, some as bladder centric with low bladder capacity and non-bladder centric with large bladder capacity. So how to phenotype BPS? Any comments?
Yes, if I can just come in. Yes,
yeah, please.
So as I said, I think if we start any treatment of BPS, phenotyping is most important, because this group of patient is a heterogeneous group of patient. They have varied kind of symptoms. And so phenotyping the patient would help us to treat the patient in a proper manner. So we know U-point system has been described by Karen, which was way back in 2009. And then they added also one point, that is S was for sexual dysfunction also added. So according to this, we all know that we can just phenotype or the exact clinical domain in which this patient falls, and then treat the patient accordingly. And I think it's very important nowadays, a lot of work is being done to understand whether actually it is different entity or it's a part of ICBPS only. So people are saying that this Hunner's lesion IC could be a totally different entity than BPS. So we have to see whether it is actually a Hunner's lesion IC, or it's just a systemic disease with BPS, or even there is a third entity which is called as pelvic hypersensitivity. So in physical examination, that just I was going to mention that we just missed out about pelvic floor examination. So we need to see the tenderness of the myofascial bands and all those areas to know whether if there is something wrong with the pelvic floor muscles also. So these three are the two most important entities which need to be differentiated from each other before we start the treatment.
Yes, Dr. Shivam, Dr. Amita did mention about the trigger points and pelvic floor examination. So she had mentioned. And
in this particular case, I'm not asking about Amita's presentation. This was regarding this case.
Yeah, this case only she talked about when she was made to make the comment. Anyway, so the only thing is that there have been phenotyping based upon what presents, like people have phenotyping, trying to phenotype. When you're talking about Hunner's lesion, it is the manifestation. So the phenotyping should be done based on etiology. If you want to succeed in segregating the treatment you should be able to do phenotyping based on etiology, and more work needs to be done on this regard at that level. Yes, Sujit, please continue.
Okay, thank you, sir. So EU has given strong recommendation on phenotyping of these patients for treatment, as these patients are really heterogeneous. So, and these have implications in diagnosis, prognosis, and treatment. So now coming to treatment, patient was counseled regarding her disease, the disease process, and she was advised for behavioral modification like restrictions of diet and to restrict diet that provokes symptoms, to engage in meditation, and also advised about concept about bladder training with urge suppression. So we started analgesics according to WHO ladder pattern, and amitriptyline was started 10 milligram daily, and it was titrated weekly to 50 milligram. So she was treated with multidisciplinary team of gynecologists, physiologists, and psychiatrists. So anything to say, sir?
Professor Apul.
So I think this is perfect. These are the steps actually which were discussed in various presentations also. This is how we proceed. So, and as just to highlight again, so although 50 milligrams have been used in various trials, but we rarely need to titrate till 50 milligrams. Usually 10 or 20 milligrams suffices in most patients.
Okay, thank you, sir. So behavioral modification studies, we have already talked. Dr. Amita has discussed a lot about, okay, Dr. Amita.
The restriction of fluid, the patient is not taking a lot of fluids. So I told like on restriction, probably the urine is going to be concentrated, so it's not going to help. So it would be adequate volume in distributed form. That would be a better idea.
Okay, thank you very much.
Restriction of the fluid.
But thank you for correcting. Thank you. So this has been already talked a lot by Dr. Amita, so I'm not going in detail. So pelvic floor relaxation physical therapy. So this is essential component of the therapy. We all agree, yes, sir? So we have to maintain dietary charting and to look for the diet elimination diet. We all agree with this. So about guidelines also, they have strongly recommended for multimodal therapy, stress management, dietary advice, and physiotherapy. So what about oral therapies used in BPS? So in clinical practice, so which oral agents we are practicing, sir?
Dr. Shivam is around.
Yes.
Yeah, so I think I personally am in favor of amitriptyline. Amitriptyline works quite well in many of these patients. And then I might add hydroxyzine in some of these patients. And if I think that there is something which is the problem is bladder centric, then I would also add pentosan polysulfate. So yeah, I think I would consider these three besides the pain management. Definitely pain would require anti-inflammatory analgesics in the latter fashion.
Okay, thank you, sir. So anything to say, sir? Dr. Taneja, sir?
No, I think this is fine. We must, as I said, in this particular patient, we would use alkalizing agent also.
Okay, thank
you. Because if there is something which is offending, we will need to go into the diet, we will need to go into the clinical examination to see if there is any, because if I suspect in young women like this who have only 3 to 4 times at night, but during the day they have 15, 16 times, that means there is an element of functional overlay, and that causes pelvic floor spasm. So pelvic floor relaxation physiotherapy, alkalizing agents, looking at the diet would become very essential for this particular patient. You can add clonazepam because it is going to be an anxiolytic. In addition, it is going to cause relaxation of the pelvic floor spasm. So that may help in this person.
Okay, thank you, sir.
Dr. Taneja, you missed muscle relaxant, your favorite traveler, one of them.
Clonazepam is what is a skeletal muscle.
You usually say so many times. Yes.
Okay, sir. Thank you very much
I
for the
just want to
information.
mention one thing, that psychiatric evaluation should be the part of management, because this patient, like Dr. Taneja told, that weight loss is there. So one component could be GI problem or some kind of thing, but the other thing could be just depression. That could be the leading cause. So psychiatric evaluation, and then because many of the psychiatric medications have, kind of interactions with the medications of amitriptyline and gabapentin, then you have to decide those in collaboration with a psychiatrist. That is a very important thing in these kinds of patients.
So whenever we are using amitriptyline, we have to know about its adverse effects and contraindications as well. So there are so many adverse effects, and whenever we are escalating the dose above 100 milligram, we should be really careful. And in cardiac patients, we should be really careful with this drug. We all agree with this. Yeah. So she followed up and she didn't have satisfactory response with amitriptyline, but had dry mouth and constipation. So to do next, how to deal with this case.
Hello.
Yes.
Doctor, you are taking? Yes.
Okay. Professor Shibam, please carry on.
Okay, thank you. So as I said, after amitriptyline, I might add in this patient hydroxyzine also. And then if the symptoms are bladder-centric, I will add pentosan polysulfetol. If the patient is not responding, then I might continue with intravesical instillation. I have to think where to start doing a cystoscopy and a hydrodistension. If the symptoms are severe and they are quite prolonged, then I might now at this time do a cystoscopy and a therapeutic hydrodistension also.
So if you look at the literature, response rate of different therapies and different drugs, they are quite variable. So maybe it may be due to the heterogeneous group of population, maybe with their different ways of evaluating as well. So amitriptyline does well. PPS, the results are really variable, as Dr. Taneja has already highlighted. And about hydroxyzine, it's mostly used in those with systemic allergy. So we went for, as she was not responding, so we went for cystoscopy with hydrodistension. And so we could see this type of picture during cystoscopy. Our bladder capacity was 500 ml at that time. So anything to say, sir? Taneja, sir?
Yes, so obviously what I have been trying to say is, hello?
Yes, sir.
Can you hear me? Yes.
Yes.
So what I was trying to say that maybe she has something which is restricting the bladder rather.
Okay, we cannot hear. What is gone? So
we can't hear you.
So anything to say, sir? Dr. Apul, sir, anything to comment?
So because as we were anticipating, actually, her functional bladder capacity was small, 170 ml. But anatomically, her bladder capacity is normal. And I can see typical glomerulations. Glomerulations are subcutaneous bleeding spots. So I can see numerous glomerulations in this patient. So I think the cystoscopy again goes in favor of our diagnosis of interstitial cystitis. And now that you have made, you have hydrodistended also, maybe this patient responds.
Okay. So how much long to distend? We have discussed a lot about this, and whether it's diagnostic or therapeutic, it doesn't matter. So short-term distension we all prefer in minutes. Though AUA has highlighted about distending for short duration, less than 10 minutes, I think we don't go for 10 minutes. Only 2 to 3 minutes is enough. I think we all agree with this. Yes, sir?
Yes, yes. Even the latest Campbell's Urology, which came this year,
yes, sir.
They also mention only 1 to 2 minutes.
Yes, sir. Thank you. So coming to outcomes of cystodistension, this has been highlighted by Dr. Sigdale. So I'm not going into detail. So it has good outcome at early follow-up, but for long-term follow-up, it has poor response rate. And on the thing to note that it doesn't appear to result in any long-term bladder dysfunction or decrease in capacity because of lack of randomization in studies. So I think grade A recommendation is still lacking. So all recommend this as grade C. So anything to say, sir, for this?
No, I think you have already mentioned everything.
Okay, thank you. So EAU guidelines, there's only weak recommendation for hydrodistension, we all know, because of lack of paucity of good studies, quality studies. So on follow-up, our symptoms got relieved significantly for 6 weeks, but gradually started deteriorating. So as we have already discussed, we can go for pentosan polysulfate. Yes, so this is AUA algorithm. So we start with the minimal invasive and go towards the most invasive, as Dr. Amita has already highlighted this, so I'm not going into the detail. So for this patient, she received capsule polypentosan sulfate 3 times a day and took for only 2 months because of high cost, but without any effect. Anything to say, sir? Dr. Shivam?
I think as this has been already said that pentosan sulfate will require at least around 3 months to show
that's a problem in this case.
efficacy. So we can't say exactly whether this is working or not in this patient. So if she's not able to afford it, then we might have to think other ways like intravesical installation.
We went for intravesical installation of heparin and lidocaine.
The other thing I just want to say that we should combine the treatment. We must have started this pentosan at the time of hydrodistension itself, because you know this is a slow working drug. So till the time the effect of hydrodistension is waning off, you might get the effect of pentosan. This is
that's the point to take notes.
Yeah.
Thank you, Dr. Amita. So we need to combine these drugs because these are long acting. It takes time. So we need to combine this drug with another procedure that gives quick effect. So we all know about intravesical therapies for BPS. So there are many installations. So in clinical practice, which ones we are using? I'd like to ask Dr. Apul.
So intravesical therapy, let me clarify for intravesical therapy, the philosophy is that the disease is bladder centric. And unfortunately, many patients, they have disease, as you mentioned somewhere in your slides, is beyond also. So those components we are not tackling by focusing our therapy to intravesical therapies. So most of us, you know, DMSO is not available in India, at least not in my part of the country. So intravesical pentosan sulfate again is not available. So actually we are just giving what the cocktail type of thing where we add some steroids, heparin, soda bicarb. So it's a cocktail that we give. So, but the problem is the compliance again. The patient has to come again and again. It's difficult for them often to get it done somewhere in their house or something. So this is usually, you know, intravesical installation therapies at least are, you know, BCG should not be given. Regarding people have given triaminosolone, which is a steroid, triamcinolone for intravesical injection instead of botulinum toxin. So this is relatively cheaper. So if you see a Hunner lesion, you can inject, you know, triamcinolone, and this will, okay, it's there, written injection of triamcinolone also there, it's a recommendation. So especially in patients it works, especially in patients who have Hunner's lesion. So, and botulinum and all these options are of course there. Cyclosporin, mostly it's given orally, but yes, intravesical therapy can also be given. You know, I have no experience with all these with cyclosporin either orally or intravesically.
So I think no one has experience with cyclosporin and other drugs maybe. So I think nice information from Dr. Apul. So still intravesical therapies are weekly recommended by EAU guidelines, but still we are using it with good short-term effect.
One thing I want to say that, yeah, if there is a problem of poor compliance, patients are coming from distant places, I started making them learn to do self-installation.
Yeah.
I have seen in different part of world also they are relying upon self-installation. So that can be done, and patients are very good in doing that. So that could be arranged for those patients.
Yes, that's a good point to note. So also, say at mild resolution of symptoms increase after stopping the therapy, as we all know, we know that. Received another hydrodistension. Same thing. So what next we can do? We all Dr. Apul has already highlighted. We can go for botulinum injection, and further on. So anything to comment, Dr. Amita? For failed therapy.
Yeah, so regarding the botulinum toxin injection, I think all other panelists will agree that personally we have not seen very good effect. Even if at all any effect is there, it is not long lasting. But yeah, anyway, we can have the trial of botulinum toxin before thinking of higher treatments. And I always combine treatments. So I have seen that there is always a good response on combining 2-3 treatments together. So usually we never get patients beyond, intravesical installation, very advanced stage ulnar disease or something which is requiring a kind of surgical management is very rare. Hardly in 2-3 patients in 100 patients might require these kinds of therapies.
Okay, thank you very much. So
I need to make one point here. So we have tried everything. We have done hydrodistension. It is not working. Oral PPS is not working. Amitriptyline is not working. So there is a thing that we are missing. We are missing a diagnosis. We should revisit our diagnosis. Just because we are at the interstitial cystitis webinar, we should not forget that there could be something else which is pushing. I will repeat a transvaginal ultrasound for the pelvic organs. This is the time to look at something there. I would also get HSV, herpes simplex virus, which at this young age is very important. So IgG and IgM for herpes simplex virus. Because I have personally found young ladies like this who will present with non-specific pain with frequency. When you do a cystoscopy, the bladder is distending nicely. But when you do the HSV, you hit the target, you apply acyclovir cream locally, and you give acyclovir orally after that, and they improve. So we are missing out on something which is very important. At this point, when you've done 2 hydrodistensions, you've treated everything, relook the diagnosis. That is the message.
Thank you, sir. So whenever the patient is not improving, we need to revisit our diagnosis. So that's the clinical principle that also applies in BPS. So should we move to BPS and pregnancy? It has been already covered by Dr. Amita, so I am not going in detail. There is scanty evidence. So triptyline and heparin are the only safe drugs considered in pregnancy, and PPS, it is well studied in animals but not used in human beings. So anything to comment on this PPS in pregnancy? I think we have nothing to comment on because there's still lack of controlled trials in human beings.
So I will tell you that my patients who have been on follow-up, they became absolutely fine for almost a 2-year period around the pregnancy, but they came back with symptoms after 2 years of delivery, and that's why when there is a pregnancy, you don't really need to give anything.
Okay. Thank you, sir. So should we move on to next case or?
I think we need to stop here because we have already overshot.
Okay.
Dr. Sujit, you have done a wonderful job moderating this session, and I'm sure that people who are still logged in would have benefited a lot. If they have any more queries, they can simply send an email to any of us and we'll be very happy to answer. And I must thank Dr. Pawan Chalise, without whose cooperation this webinar could not have been conceived. and of course my so learned panel, starting from Professor Shivam, Professor Rapul, and Dr. Amita Jain, and the colleagues from Nepal. They have been wonderful. I'm so happy to know that a good work is being done, because when we started this movement in 2016, Amita Jain would remember, I met her and I said, look, we need to do something in this part. She would remember our first meeting. I just picked it up from somewhere and called her and said, let us meet and do. This is what has the result. The result is the webinar with so many people still logged in, 72 people still at the present moment at 8 p.m. Thank you, everyone. Thank you, Swati Spentos, for taking the lead. Thank you, Deepti and Cheshta, for your untiring efforts. We could depend upon you, and we have, and you've done a wonderful job. Dr. Pawan Chalise, please, can you add on something to which I may have missed?
Yes, thank you, Dr. Rajesh, for giving this opportunity to be linked with your society. And I'm sure in Nepal, as we are discussing that, where urology is now budding, and now it's already been a tree, a big tree. So we need to have this kind of fruits in our trees, like this kind of disease, which has really has some kind of orphan disease or some neglected part of this in our society. Although we have lots of prevalence, still we have high prevalence of this disease in our society, and we need to educate ourselves, our urogynecologist colleague, our psychiatrist, and it's all a team reports, because today we have learned a lot from your side. And I think I'm very much sorry to Dr. Sujit that he is well prepared. He has 2 cases, and I think second case we have to discuss in some other forums, and we have to get that time in the future. Thank you very much. For I especially would like to thank the faculties from NOUS and all your team efforts, and the faculties from GIBS to be here in this platform. And there are lots of good response from all over the world, and I think we need to continue this in our future days too. Thank you, Dr. Rajesh.
Sanjay Pandey had to leave for an emergency. So on his behalf also, I will convey thanks to the organizers of the webinar.
Yeah, and also thanks to and also thanks to Deepti and her technical team, and the Swati Spentos Private Limited, who gave this platform to have this discussion, and without their support it had not been possible.
So have a nice evening, all of you. Enjoy. Have a
thank
nice
you.
time.
Stay safe, because
Bye-bye.
this is a hard time for all of us, and thank you.
Thank you, Dr. Pawan, Dr. Rajesh, Swati. Thank you.
Thank you all for this
Thanks.
session. Thank you very much.